Right. Welcome back, everyone. Hope you're all doing well. So today we're going to talk about the three other lectures. We're going to talk about the basic arrhythmias lecture. We're going to talk about the ischemic changes, which, to be honest, is my favorite lecture. And then, of course, we're going to talk about the chamber abnormalities, like the atrial enlargement and ventricular hypertrophy. We'll talk about all of that, inshallah. طيب. Pretty much, I just wanted to bring a few slides over here. Just some things that would help you for those who didn't attend yesterday. So the following slides, I'd recommend screenshotting. They could just give you a better idea of some of the important topics we talked about. For example, if we're looking at yesterday's topic, yesterday we looked at tachyarrhythmias and bradyarrhythmias. I showed you guys an algorithm to go. So if you think it's a tachyarrhythmia, you can look at the QRS, you can look at the regularity, you can look at the P wave, and then an axis if needed. For the Brady arrhythmias, you look at the PR, you look for dissociation, and you look. I told you guys a little bit about how instead of just trying to solve the ECG all the way from scratch, try think what this could be, and then try look for things that will help you identify it. We're going to talk about a bunch of these today, inshallah, as well. But this is something I thought that might help you guys. This is also something important. I just wanted to remind you guys of some important information, which was that in terms of distance, this is 1 millisecond, or sorry, 0.04 seconds, or 40 milliseconds. For one small square is equal to 0.04 seconds. And in terms of height, one small square is 1 millivolt. One is 0.1 millivolts. And basically, one small square or 5 small squares make up a large square. For whatever the value of the small square is, multiply it by 5, and that's how much it is in a large square. So the large square in terms of time, so if one small square is 0.04 seconds, the large square would be 0.2 seconds. And in terms of height, if this is 0.1 millivolts, one large square would be 0.5 millivolts. And because of this, we know that 1 millivolt as a whole would be 2 large squares in height, and 1 second as a whole would be 5 large squares in width. I think that's something very important. And I said yesterday that you guys should be familiar with the lengths of different waves and intervals. For example, the P wave, the PR segment, the QRS, the normal height of the ST, which we will talk about today, inshallah. This U wave, I'll talk about at the very end, but I don't think you guys need to know it for now, at least not with the arrhythmias lectures. Here was a tachyarrhythmia formula, which we talked about yesterday. And I'm just going to leave it here for a few seconds because we're going to talk about arrhythmias anyways. I just wanted to leave this here, just in case anyone didn't take a picture of it, they want to. And then I'll go back for another few seconds, just in case. This is the Brady arrhythmias. I took out the anterior and posterior fascicular blocks because I looked at the lecture and they were hidden. So I'm assuming that the doctor didn't cover them. No one told me like they were covered or not covered. It's better not to cover them if they weren't covered because it gets very annoying. So I'm going to give you guys another few seconds here, just for screenshots. Okay, and this is another thing that's also important in basically the axis determination. I want you guys to get familiar with the semicircle idea. And in we need to use 3 leads to determine the axis. And when we combine the area which these leads take and the area that encompasses them all, that's how we know where the axis is. So if it's anywhere from -30 to 90, that's normal. Here would be right, here would be left, and then this would be extreme axis. There's the picture to show you guys that in the back, but I want you guys to get familiar with this whole semicircle idea because I think it makes things easier. Now, one thing that I feel like may confuse you guys with ECG readings is that sometimes it's a tachyarrhythmia, but it doesn't look like a tachyarrhythmia. It looks like a normal rate, or it looks like it's called a bradyarrhythmia, looks like a tachyarrhythmia, or it's a tachyarrhythmia, but it looks like a bradyarrhythmia. That can throw you off. Sometimes it might be better to just jump all the way and try to identify any abnormalities. For example, with the atrial flutter, they have the sawtooth pattern. You don't need to go through this whole system, wide QRS, narrow QRS, whatever. If you see the sawtooth and you look through it backwards, then you know you're looking at atrial flutter. And the fibrillation waves, for example, with atrial fibrillation, the progression in the Mobitz 1 type 2 AV block, Yeah. Now we're going to talk about the basic arrhythmias lecture. I'm going to go through this lecture quickly because really the only arrhythmias that we didn't take in this lecture, that are in this lecture, but were not in the previous two lectures, were the premature beats. But the way I want you guys to understand is that there's another approach to arrhythmias. And no, we actually, rather than identifying them by their QRS complex, we identify them by common features they have in the location. So for example, there are arrhythmias that originate in the sinoatrial node, or arrhythmias that originates in the atria or the junction. So there's all sorts of different places in which an arrhythmia can originate. So this is another system, and whatever system you decide to use, it's up to you. At the end of the day, this is your decision. But this lecture kind of gives you another way at looking at arrhythmias. Of course, one way which they're differentiated also is the speed. So you guys should be familiar with what is the normal. So what is the normal firing rate, or what is the normal heart rate if this is the chief pacemaker? So someone in the chat, just tell me in the sinoatrial node, what is the normal rate? 60 to 100. Yep, it's 60 to 100. That's normally from, so assuming that the impulse is coming from the sinoatrial node, it's 60 to 100. And if it comes from other places, it usually gets slower. And then pretty much being familiar with all of the arrhythmias we've talked about. But here, this slide kind of gives you an idea of the way in which we can organize some of these arrhythmias. For example, in the sinus rhythms, they are regular. So if we call it just sinus bradycardia or sinus rhythm or sinus bradycardia, these are regular. There are a few irregular ones, but usually they're regular. And the PQRST, so the way in which the amplitude looks, it's normal. The only thing that can differentiate is the speed and the regularity to some extent. With the atria, usually they're irregular, except the tachycardia, and flutter can sometimes be regular, sometimes it can be irregular. And being an atrial wave, it doesn't mean that it needs to have a P wave, because there's a problem. Usually, if it's an atrial impulse, there's a problem. The junctional don't have a P wave, and they are regular beat. They're all regular except the premature. We differentiate the junctional by the heart rate. And then in terms of the ventricles, for example, if it's a ventricular rate, the QRS by definition needs to be wide. And there is no P wave as well. They're usually irregular except for ventricular tachycardia. And then we have a few beat types, for example. So premature beats, if it's premature anything, it needs to look irregular. The sinus rhythms, they're usually not pathologic. Even when we talk about different sinus arrhythmias, they're not necessarily pathologic. Sinus rhythms are pathologic if they have symptoms. And we talked about an arrhythmia yesterday, which does have symptoms, which we will talk about again. But I'm going to leave it in the chat in case anyone remembers what it's called. And then each part of the cardiac conducting system has a normal heart rate. So if it's coming from the sinoatrial node, it's 60 to 100. From the junctions, it can be 40 to 60. From the ventricles, it can be 20 to 40. So does anyone remember the sinus rhythm or the sinus node pathology, which oh wait, I just realized it was mentioned. Sick sinus syndrome. Never mind. Never mind. Cancel. Okay. Like here they talk about arrhythmias. Arrhythmia by definition is when the heart has an abnormal rhythm. Simple. There A means no, and rhythm is rhythm. So it doesn't really have a rhythm. Now, there are different mechanisms of arrhythmia. We talked about normal impulse formation, such as abnormal or enhanced automaticity, abnormal impulse conduction, such as re-entry pathways, and then blocking conduction at certain parts. We talked about this yesterday. And then there are different types of beats. We have narrow and wide complex tachycardias. We have extra beats, which are usually premature. We have bradycardias. Like here, they talked about the rhythm analysis. So what is the heart rate? Is it regular or irregular? Personally, if you're going to go by the system, I would say ask yourself if it's regular and irregular first before determining the heart rates. And for determining the heart rates, you can either just check the distance between the RR intervals, and then see how many large boxes are between that, and then go from there. Or if it's irregular, you look at the 10-second strip, and you see how many QRS complexes there are, and you multiply that by 6. And I'll show you guys an example in case we do see one. Is there a P wave? Are the QRS complexes narrow or wide? Is there a relationship between P and QRS? And then, of course, are the intervals normal? And then also the axis. Like this right here it's a pretty simple rhythm. So this is regular. the P waves are present, the PR is normal, the QRS is normal, and the heart rates, as a matter of fact, it's 1, 2, 3, 4 big boxes. It's barely even 4 big boxes. It's actually 3 and I guess a few quarters of a big box. This is by definition sinus rhythm, normal sinus rhythm. This is a normal heart rate. Like nothing pathological about this, but you should appreciate that this is normal. Now here, do you guys think this is faster or slower? Slower. By definition, because this is slower, the QRS is normal, the P is normal, the PR is normal. This is by definition sinus bradycardia. Now, going by the regular approach, so let's say I'm going to do this one in the approach that was described in the slides, just in case anyone wants to be familiar with it. Here we have, first of all, we have what looks like a fast rhythm. It looks like it's less than 3 big boxes. So I think this is fast. Also, it's regular. Then I look, for example, there is a P wave, there is a QRS, the relationship seems normal, the duration seems normal. I can't really tell the axis because this isn't a 12-lead ECG. But the only thing I see here is that the heart rate is fast. For this would be a sinus tachycardia. For these 3 are normal and they're regular. And they don't necessarily mean that there's something pathological happening. They could just happen due to some sorts of physiologic conditions. For example, you might have sinus tachycardia because of a fever, or you might have sinus bradycardia that might just be your normal heart rate. It's fine. But here, is this regular or irregular? It's irregular. Very good. But this is irregular. Here we have a period of what seems like a faster heart rate versus a period here that looks like a slower heart rate. But there doesn't seem to be a pause here. As a result, I see that there's this, I would say that this maybe would even be a tachycardia, and this would be a period of bradycardia. This is what we would actually call sinus arrhythmia. Sinus arrhythmia, it's nothing other than how does sinus rhythm change with deep inspiration and expiration. I want you guys to guess, in the area of tachycardia, do you think we have inspiration or expiration? So is the person breathing in or out in the tachycardia right here? They're breathing in, very good. They're breathing in this case. As a result, this is inspiration. In inspiration, we'll have tachycardia. In expiration, we'd have bradycardia. Again, this isn't pathologic. This is actually normal. Here, we have this area. It's a very long pause. Like, look, if you see the pause here, it's 1, 2, 3, 4, 5, 6 big boxes. There is a bradyarrhythmia here, which is fine. But here, for example, this is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. I forgot to count these, but that's a very big pause. We actually call this sinus pause right here, or sinus arrest. So what happens here, we have just regular heartbeat, and then all of a sudden, boom, just pause. This is pathologic. This isn't supposed to be a normal heart rate. This is also called sinus pause, very good. Either arrest or pause. But just going by the regular way. So first of all, it looks irregular. And then it doesn't seem like, it seems like there's a bradycardia here. There's a bradycardia over here. The heart rate doesn't seem to be too high, if I'm being honest. The P looks normal. The QRS looks normal. There's a relationship between them. But this interval is very long. This interval is too long, actually. So because this interval is too long, I would call this a sinus pause. But over here, what we have is, you see over here, we have an area where we have what looks like a tachycardia, because it looks around 3, maybe even less, small boxes, big boxes, sorry. And then it goes and switches to a bradycardia. Over here, or this is a better picture, sorry, I don't know. This is a much better picture that shows it. We have this period here of tachycardia. I think it's very clear and prominent. And then over here, we have this period of bradycardia. And there's a pause over here. What's it called? This is what we call tachybrady syndrome. If a person has symptoms, we call this sick sinus syndrome. There's tachybrady syndrome. So there's an area of tachycardia and bradycardia, and there's a pause. We call this tachybrady syndrome. And if a person's symptomatic, we call it sick sinus syndrome. That's it for the sinus rhythms. Just to remember the features, the PQRST is normal. They can be regular or irregular, and they're not really pathologic. So does anyone have any questions about the sinus rhythms? Okay, so tachycardia is basically sinus. Okay, that's a good question. Not exactly. Let me show you. So in sinus pause, there doesn't necessarily need to be a tachyarrhythmia or bradyarrhythmia. It's just you have these QRS complexes. It's regular until it pauses. Once it pauses for this long of a period, this is a sinus pause. And if you see, for example, this is 1, 2, 3, 4, 5 big boxes. This is around 5 big boxes, I'd say. But it's still a normal heart rate. But it's just normal heart rate, pause, normal heart rate. So that's the sinus pause. Now, tachycardia syndrome, you need to have a part of tachycardia, and you need to have a part of bradycardia, and it needs to be obvious. So because of that, and there needs to be a pause between the tachy and the brady. So there is a pause in tachycardia syndrome, but we don't call the sinus pause, because again, the sinus pause describes you have a normal sinus rhythm and then it pauses. So sinus pause is just one drop among the normal rhythm. Yeah, that's a good way of describing it. And all of a sudden, it's just one beat doesn't happen for some time, or the sinus rhythm just stops for some time, and then it goes back. Does that make more sense to you guys? It's a good question, by the way. Alhamdulillah. Okay. Well, let's move on to the atrial rhythms. And atrial rhythms, they are irregular except the tachycardia and sometimes flutter. Now, with the atrial rhythms, basically, another thing to note is that they may or may not have a P, but it doesn't need to be present. Now, the one thing I want you guys to remember is the way I kind of look at the PQRST. So, for example, I look at the P as the atria, I look at the QRS as the ventricles, and I look at the ST as the whole heart, because it can elevate or depress in certain conditions. Basically, for example, if there's no P wave, that means there's something wrong with the atria. And it makes sense, because you wouldn't really have an atrial rhythm unless there's something wrong with the sinoatrial node or the atria in general. So let's go into this one. Here we have an irregular rhythm. And then all of a sudden, we get this one random beat that's not even supposed to be there. So we call this a premature atrial contraction. The thing with premature atrial contraction, the way you should remember any sort of premature beat is that it's not supposed to be there. It's beating too early. So pretty much what happens is that you might get an abnormal P wave. So this may look normal. There is a P wave here. And then in this one beat right here, the P wave has an abnormal morphology, or it's hidden within the QRS, and it's not following this regular pattern, as you guys can see here. So because of this is what we call a premature atrial contraction. It's just this one random beat. And if you go back, for example, if you look, this is regular, and then over here you have another premature atrial contraction. How do I know that this is a premature atrial contraction? Because this looks like a normal rhythm, and then all of a sudden, for some reason, it becomes abnormal because of an inverted P wave. So I know that there is something wrong at the atrial's end, but the rest of the morphology seems kind of normal. I think I might have confused, so let me just summarize it again, which is basically you have a normal heart rate, and then you get this one random beat. This one random beat, what are its characteristics? Its P wave is abnormal. The P wave is there, but it's abnormal. Sometimes it might be hidden, but usually it's abnormal. And it's disrupting the normal sinus rhythm. So here you go back to this normal rhythm and then premature again. Here's another example of premature. As you can see here, this beat right here is premature because it has abnormal morphology. This one as well. So you're really looking what is the normal rate and then what looks wrong here. So the premature makes the whole rhythm irregular. Here they're showing you why it happens. So you might have some focus in the atria that causes the atria to contract rather than the normal sinoatrial depolarizations. So, and it forces it to contract early, so it's premature. Here we have what seems to be, for example, a normal heart rate. Starting off, it looks regular. It does seem like a tachycardia, so it's fast. And then I look at the P wave, QRS, and then, of course, are the intervals normal? So starting off with the P wave, it has an abnormal morphology over here, but all of them have this abnormal morphology. The QRS, it seems narrow, which is fine. The P and the QRS is related. This abnormal P has a QRS. Every abnormal P has a QRS related to it. And then, for example, the intervals, they do seem normal, but the RR interval is accelerated. So the only thing that's really wrong here is the P wave, and it's inverted. So this is what we would call, for example, an atrial tachycardia. And the other way you check for an atrial tachycardia is you're looking for axis deviation. So even if you don't see the P wave, if you're looking at a 12 lead ECG, and you see, for example, right or left or extreme axis deviation on what seems to be a normal tachycardia, that's what we would call atrial tachycardia as well. Like here's an example. So here, for some reason, the axis is normal, but the P waves are abnormal, which is fine. So you either need to find and know the axis is abnormal or the P wave is abnormal. And if you look at some of these leads, for example, lead 2, the axis is normal, but the lead is abnormal. You're either looking for axis deviation or you're looking for a abnormal P wave. These are the two characteristics for atrial tachycardia. For example, like the ones we saw yesterday, the P wave looked normal, but the axis was abnormal. Here, the axis is normal, but the P wave is abnormal. I've sent the slides. I think you guys will have a better chance to look at the differences between them and appreciate them. Again, there's some sort of focus in the atria that's causing this to happen. Now here, for example, this looks kind of regular in this case. The heart rate doesn't seem to be a tachycardia, but I do see this abnormal pattern over here. Do you guys know what this abnormal pattern over here is called? Sawtooth, very good. This is sawtooth pattern. And what arrhythmia do we see sawtooth in? Atrial flutter, very good, very good, very good. Here, the heart rate is actually 250 to 350. The reason they're saying that this is a heart rate between 250 to 350, although the QRSs don't match that, is because the atria are firing this much, but the ventricles are only responding to so much. Like they can only respond to so much level. Here, the heart rate is actually extremely high, but the ventricles can't respond to this high level of heart rate. So you don't really see a PR interval. You don't even see a P wave. The QRS is normal, somewhat. But if you look at the relationship, for example, all of these P waves, they don't necessarily have a QRS following it up. But it is still kind of regular. So you see like 1, 2, 3, and then here. 1, 2, 3, 1 here. 1, 2, 3, 1 here. But it does look regular, but this can also appear irregular. So this is atrial flutter, as you guys said. And the key thing you're looking for is a sawtooth pattern. Although this does not look like a tachyarrhythmia, it is, and the sawtooth pattern is how you know. Here's another, for example, this is an irregular atrial flutter. Because like I said, atrial flutter can be regular, as we see here, or irregular like this one right here. And here's another example of atrial flutter. Yeah, this is the 12-second, this is the 10-second lead I was talking about. And when I show you, hopefully I think there might be one for an irregular one, and I'll show you guys how to calculate the rate based on something irregular. Okay, here, what I see, for example, is I see it's irregular, first of all, and it seems like a tachyarrhythmia in most of these places. But more importantly, what I'm looking at are these waves right here, these fibrillation waves. This doesn't look like a saw. Like you guys can appreciate the difference between this, for example, and the sawtooth pattern. And the rates here, they say it's 350 to 500, but the ventricles can't respond to that level. For example, here, sometimes with flutter, the ventricles can respond to some of these. Like to a certain order of P waves, eventually they can respond. Here, it's actually random. There's so many P waves, the ventricles don't know when to respond. There is no P wave, because there's no PR interval really. The QRS is normal still. But do you guys know what this one is called? So just to repeat, the QRS is narrow, it's irregular, there is no obvious P wave, and we see these really abnormal waves. But do you know what we call this? AFib, very good. Atrial fibrillation. Here's another example. So you guys, maybe I think one of the things you saw was the fast versus slow response atrial fibrillation. And pretty much it's how often can the ventricles respond. So this looks like a tachyarrhythmia, but you'll see some atrial fibrillations that actually look like Brady arrhythmias really. And I maybe they'll bring an example. No, they won't. Okay. Here, for example, this is another example of atrial fibrillation, and I'll show you guys how we calculate the rate. So over here at the bottom, this is the 10-second lead. And in ECG, so you get the 12 leads, and then sometimes they just pick 3 leads, which they focus on for 10 seconds. So let's look at lead 2. We have how many QRS complexes? We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. We have 11. We multiply that by 6, we get 66. So that's the heart rate here. How do you differentiate between AFib and artifact? That's a very good question. So with artifacts, what you might see in terms of artifacts is that when you're doing the ECG yourself, you'll know. Like they'll never bring you a question and tell you that the answer is going to be an artifact. Pretty much what they're like, this is more dependent on the operator themselves, like the person doing the ECG. There is a period of time where they have to wait before they actually start calculating the ECG. And that's because they're letting the electrodes just settle in. And once it becomes stable, they know that this is when we start calculating the ECG. But that's a very good question. This is something that you'll actually see when you're actually doing an ECG, inshallah. But did I answer your question? Another thing to mention, and the more common thing you'll actually see on as an artifact rather than atrial fibrillation is actually ventricular fibrillation. And you're more likely to see that as an artifact rather than atrial fibrillation. Yeah, but it's a very good question. It's a very interesting question. I like that question. Good job. طيب. Atrial, are we all clear? Any question? Alhamdulillah. طيب, just to recap, they may have a P wave, they may not. Premature beats always make it irregular and they always look like they're out of place. For example, we have regular rhythm in tachycardia and sometimes in flutter. Flutter may sometimes be regular. With flutter and AFib, it may not look like a tachyarrhythmia at times, but you have to find the characteristic features. For flutter, it's the flutter waves, and with which are the sawtooth pattern. And with atrial fibrillation, it's the fibrillations themselves, which are these tiny little waves right here. Like here. Here we have so this is a junctional rhythm. The characteristic of junctional is that they're regular except for one of them, which is this one right here. They don't have a P wave. So the reason they don't have a P wave is because the sinoatrial node isn't the main contractor now. Now the contraction force is at the junction itself, the atrioventricular junction. The QRS is still narrow, and we differentiate the different types of junctional rhythms by their heart rates. So we called, for example, accelerated tachycardia, junctional rhythm, supraventricular tachycardia. We differentiate them by their heart rate themselves. But here we have what seems to be a junctional tachycardia. How do I know this? There isn't really there is a P wave in this case, because again, this is irregular, but there doesn't need to be a P wave. And you'll see sometimes without a P wave because it's a junctional tachycardia. Or not a junctional tachycardia necessarily, it's a junctional abnormality. With the premature junctional contraction, it does seem kind of normal, but it's still premature. The reason being, in a junctional rhythm, even a junctional arrhythmia is regular. So that's the way you can look at it. You see, sometimes there isn't a P wave. Like, for example, this one doesn't have a P wave. Well, this one right here is actually the abnormal junctional beat. Premature beats, in general, you have a normal rate, and then you have something that just disrupts that for some reason. For this beat, doesn't have a P wave. The reason it doesn't have a P wave is because the focus for which triggers this contraction is from the junctions, and a junctional rate should not have a P wave. Again, it's out of place. It disrupts the regular rhythm, and it doesn't have a P wave over here. So I hope that makes sense. Pretty much, you have something that looks regular, and then all of a sudden, boom, this one irregular guy. Here they're showing you, it's coming from the junction. Played. Here, we have the heart rate, they're saying it's 40 to 60. So this is regular. The heart rate does not seem that fast. There is no P wave. And because of this, there isn't really a PR to check. And the QRS is normal. So what do you think we call this? I just want guesses. Okay. Is this... okay. This is a junctional rhythm, so it's going to start off with junctional. So my question, is this a junctional bradycardia? Is this normal for the junction? Or is this a junctional tachycardia? Or what exactly is going on? Okay, you guys are saying normal. Like, can someone tell me why it's normal? Why can we say, no, this isn't a tachycardia or bradycardia? Why this is normal junctional rhythm? If you don't know, it's fine, but I want to give you guys the chance to... Firing rate of the AV node, very good. The junction themselves, they fire at 40 to 60 beats per minute. Very good, thank you so much. This is actually normal for the junction. So here the heart rate is 40 to 60. So it looks normal, but there's no P wave, and the heart rate is 40 to 60. Here, it gets a little bit faster. So the heart rate here, they're saying it's 71. It's still regular. The P wave isn't here. The QRS is normal. Basically, we get a little bit faster here. So do you think we call this a tachycardia, yes or no? And if we don't call it a tachycardia, khalas, you answered for me. Very good. So this is accelerated because the tachycardia is above 100 in terms of junction. So anything from 60 to 100 in junctional rhythm, in a junctional rhythm, is called accelerated junctional rhythm. Very good. Here, the heart rate is above 100. The PRS is still normal. The P is still not here. But it's regular. For this, we would call this a junctional tachycardia. For in terms of the rhythm is 40 to 60, accelerated is 60 to 100, and tachycardia is 100 beyond. And then we have this. So let's say it gets from 100 to 150, we would say. And then it gets to this point right here, where it becomes 150 to 250. No P, the QRS is normal, the heart rate is really fast. It's above 150. So in this case, what do you think we would call this? Okay, for those of you who attended yesterday, we did talk about this arrhythmia. And no, it's a arrhythmia with no P wave, regular, narrow QRS. SVT, very good. Yes, supraventricular tachycardia. So pretty much, when you're looking at a tachycardia with no P wave, the way you differentiate it is by the heart rate or by the flutters. So that's more information to add to you guys. So for example, supraventricular tachycardia is anything from 100 to 150. Beyond 150 is when we call it a supraventricular tachycardia. Ooh, again, it's just referring to the different location of the focus for this whole rate, as a matter of fact. Still regular. It's extremely fast. And imagine your heart beating at 200 beats per minute. That's crazy. So that can happen with this. Blade, the junctional. Do you guys understand? Alhamdulillah. Anything that doesn't make sense, just to recap, junctional rhythms, except for the premature, are regular. They don't have a P wave. The QRS is narrow, and we differentiate them by their heart rate. If it's 40 to 60, it's normal. If it's 60 to 100, it's accelerated. If it's 100 to 150, it's tachycardia. And if it's 150 and beyond, it's supraventricular tachycardia. طيب الحين الventricular rhythm. طيب here it seems regular. طيب you still there's a P wave in this one, there's a P wave in this one, and then all of a sudden you get this right here. And then it just goes back. So first of all, is this a normal beat? Is this an arrhythmia? Do you know what we would call this kind of beats? Do you remember? Where you have a normal QRS and then this one random beat that's out of place. Do you know what we would call this in general? It does have a wide QRS before premature. That's the word I'm looking for. And no, this is a premature beat. You have a normal rhythm, and then all of a sudden, bam, this guy comes in. But my friend, you are correct. This does have a wide QRS. So I want you to tell me what we would call this this thing right here. What would this be called? Premature ventricular contraction, PVC. Very good. طيب. You have a sinus rhythm, but this one random beat just comes in, has a wide QRS, and it disrupts the whole entire thing. And this is what we would call a premature ventricular contraction. Here it's just showing you that the focus now is from the ventricles. So here they can be monomorphic, they can be polymorphic or unifocal or multifocal. This just means they will either look like the same because they come from the same area, or they will look different because the focus is from different areas. But that's just something that they're trying to show you. And here they're showing you the difference between premature and atrial, ventricular, and junctional contractions. You guys seem like I think you understand it pretty well. Ventricular has a wide QRS. This has no P wave. This has an abnormal P wave. Here we have this QRS. Is it wide or narrow? Yeah, it's wide. Are you guys sure it's wide? Like how confident are you guys that this is wide? Like, no, it's wide. It's wide. It's really wide. No, guys, it's wide. I was just trying to throw you off. Sorry, guys. It's really wide. But pretty much this is a really wide QRS. For wide QRS, we see this in ventricular. We see this in some sort of ventricular rhythm. The rhythm here is not regular. It's actually irregular. I know we only see two of these, so we can't differentiate, but if you were going to look at the sort of full lead, generally this type of arrhythmia, which we will name in a bit, is not regular. The heart rate is actually 20 to 40. Do you guys think this is normal for this source? Is this the normal heart rate? For this source, is this the normal heart rate? 20 to 40. 25 to 40, 20 to 40. Yeah, exactly. So it can, some people say 25 to 40. Based on your slides, it's 20. But very good. Yeah, this is actually the normal. This is the normal for this source. Yes, this is normal. But this is what we call idioventricular rhythm. For pretty much, it's irregular. The QRSs are wide. There is no P wave. And the heart rate is 20 to 40, 25 to 40, depending on what system you're using. So as a result, this is the normal ventricular rhythm. Which part of the heart is firing this? Very good question. This is the ventricles. The ventricular conducting system is the one firing this. The beauty of the heart in general is that there's always someone that's going to take over. So for example, if the sinoatrial node gets knocked out, the AV node will take over. If the AV node gets knocked out, the junction will take over. If that doesn't get knocked out, someone's going to take over regardless. Like you'd have to knock out the Purkinje fibers. Yes, these would be the Purkinje fibers, or even the bundle branches, but it depends exactly on a lot of things. Like here, but very good. Mashallah, you guys seem like you know a lot of this, which is really, really nice. It makes me happy. Like here, the rate is regular. The QRSs are wide. The heart rate is above 100. And there's no P wave. Do you guys know what we would call this? Ventricular tachycardia. Mashallah alayk. Very good. This is ventricular tachycardia. One thing to keep in mind is the way you should see when you see this ventricular tachycardia, you need to defibrillate. Someone with this will probably be in syncope, or they might be on the verge of cardiac arrest or going into ventricular fibrillation. Here, this is another picture of ventricular tachycardia. This is monomorphic ventricular tachycardia, by the way. The reason we call it monomorphic is because morph means shape. So this is only one shape right here. And yeah. But here, does this look normal or abnormal to you guys? This is obviously abnormal. Is this regular or irregular? It's all over the place. Exactly. This is the shakhbat shakhabit rhythm, which is called ventricular fibrillation. These QRS complexes are so complicated, they're not even considered QRS complexes. So we call this ventricular fibrillation. Pretty much, there's all sorts of chaos. But there is a case where this is actually normal. I want someone to tell me, where could we see this in a normal human being? Whoever gets it right, they get a chocolate on tomorrow, inshallah, if they're in the library. But when can we see this in a normal person? Being I don't think someone would normally get electrocuted, but I like the guess. Well, it's a little violent, don't you think? Salah, the response deserves a chocolate, fine, but I'm looking for another one. You guys mentioned it earlier. Caffeine intake? No, not caffeine intake. We mentioned it earlier. When can we see this in someone normal? I will give you guys a few minutes to figure that out. Okay, we'll save this for the end. But the first person to answer me when we can see this in a normal person gets a chocolate tomorrow. طيب, let's move on. Yeah, this is basically, this can happen this can lead to asystole. It's very bad. You don't want this in a person. And yeah, this is what we see. This right here, you guys know this, I think, I hope. There's no P, there's no QRS, there's no PR, there's no rhythm, there's no rate, there's nothing. What do we call this? Asystole, very good. This is asystole. The treatment for this would be CPR and epinephrine. And you can only confirm asystole in 2 leads. For example, if you see one lead with asystole and the other still has, for example, ventricular fibrillation, or there's only one lead which doesn't have, for example, any sort of activity, it looks asystole. We don't call it asystole. We need 2 leads. So here they're showing you 2 leads because this is asystole. Wait. We're going to go on to the heart blocks, but before that, do you guys understand everything from the ventricles? Cool. Heart blocks are easy. We have 3 types of heart blocks, technically 4. We have first degree, second degree, and third degree. We talked about them yesterday, so I'm going to go through them very quickly. This is first degree because the only thing that's happening here is a PR delay right here, which I hope you guys can appreciate. Over here, we have progressive PR, we have progressive RR interval increase, and then eventually a beat drop. How do I know that this is a beat drop? There's a P wave with no QRS following it, or no QRS responding to it. So because of this, I know that this is, in fact, a Mobitz 1, or a second degree type 1. And here they're showing you the PR delay. Or sorry, the progressive delay in the PR. Yeah. Over here, it's regular. There's no change in the RR intervals, and then all of a sudden, there's a beat drop over here. We know this is a beat drop because there's a P wave over here with no QRS to follow it, and then it resumes to normal. So this is a Mobitz 2 block. This one's actually more severe. And then here we have P waves which aren't associated with QRS complexes, and this is a third degree heart block or complete heart block. Here's another picture of complete heart block. Well, I think this came in our exam last year. This picture in particular, I think it came in my exam last year for the midterm, but I don't exactly remember, but I think it did. Either the midterm or the final, but I remember this picture very vividly. Played. Now we're going to practice again. If anyone can tell me when would we see the ventricular fibrillation wave normally in a normal person? Again, the chocolate's still up for grabs. No one's answered me yet. I am waiting on an answer, or I'll just eat the chocolate for myself. Oh, someone has an answer. Surgery? No, not surgery. You don't want VFib in a surgery. Again, you guys have mentioned this earlier. You Googled and still didn't find it. Again, it's something Dr. Bender mentioned to us. He didn't offer us a chocolate, but he did ask us when we would see it in a normal person. We didn't know the answer until he told us. A hard blow to the chest? Not exactly. It's physiological? Yeah, it's kind of physiological. Is it caused by drugs? Okay. Again, the patient This is a normal person. They're breathing normally, they're seeing normally, and they're relaxed. But when you put the ECG leads on them, you see ventricular fibrillation. It's not because of drugs, it's not because of something pathological. This is something that they just see. And you guys mentioned it earlier. Anyways, do you guys want me to answer, or do you still want time to think about it? Okay, خلاص, I'll wait. طيب, أبشر. Anyways, let's practice so we don't take too much time. Over here, I want someone to just tell me what it is and how you got to that conclusion. And then we could take like a 5-minute break afterwards. Okay, like, how about we do this? First of all, is there a P wave? Are the QRSs narrow or wide? Narrow. Is it regular or irregular? Okay, so it's regular, narrow QRS, and there is no P wave. For where is this rhythm aslan happening based on this information? Is it happening at the sinoatrial node? Is it happening at the AV node? Is it happening at the junction? The junction, yes, this is happening at the junction. Now, in the junction, we differentiate them by the rates. So now, is the heart rate, for example, 40 to 60, or 60 to 100, or 100 to 150, or 150 and beyond? Well, based on that, each one has their own, and each one has its own answer. Tachycardia, very good. Yes, this is junctional tachycardia. It's above 100, but it's under 150. Very good, thank you. طيب, over here. Wait. Okay, I guess there's nothing here. Like, what, let's say, you know what, I'll draw one out for you guys. طيب. Let's get a little creative. طيب. Like, can someone tell me what this is? It's history. I don't know how you guys got that very quickly. MashaAllah. Like, anyways. Oh, guess I should erase these. Okay, anyways. Moving on. Like, over here. Like, how about we break it down? So first of all, does this look regular or irregular? Or did someone? Oh, okay, yeah, it is premature atrial contraction. Very good. Like, person whose name I will not say because I don't think they want me saying their name for the sake of the recording. But how did you conclude that this is a premature atrial tachycardia? And what made you know that this is PAC? Abnormal P wave disrupting the normal rhythm. Very good. Yeah, early QRS. Abnormal. It's an abnormal P wave as well. So we know that this is atrial. Yeah, very good. Great job, guys. Okay. This right here. Sinus tachycardia. Try again. How about I zoom in into the leads at the bottom? Let me do that for you guys. Maybe it'll show you more clearly. But I get why you would think that this is sinus tachycardia. SVT, very good. This is SVT. طيب, how did you conclude that this is SVT? More than 150, no P wave. Very good. QRS is regular. QRS is narrow. Good job, guys. Okay. So yeah, that's it for the arrhythmias lecture. Does anyone have any questions? If not, we'll take a 5-minute break. Where is the VFib answer? Do you guys want me to tell you the VFib answer? Or do you want to think about it more? It's up to you guys. Yes, as in, should we know the causes of this arrhythmia or just the structure? Good question. So they care more about, okay, I'll start off with this question. In terms of knowing the causes of the arrhythmia or not, there are certain causes which you do need to know. For example, AV-NRT for the supraventricular tachycardia, as well as Wolff-Parkinson-White. Also, you should know that multifocal atrial tachycardia, MAT, is caused by COPD. But in terms of like very specific pathophysiologies, you don't need to know them. The reason I tell you, like, for example, this is because of some focus here, is just so you understand if something comes from this part of the heart, it has disappearance on the ECG. So that's the only reason I tell you guys, for example, that it comes from this place or it doesn't. But in general, it's more about, can you identify them? A lot of the questions are focused on identification. But it's more important to identify them. But that's an excellent question. Okay. For the answer, and you guys mentioned this earlier, is that you will get this. This is an artifact. This can be an artifact. For an artifact in any sort of reading, whether it's an electroencephalogram or an ECG or electrocardiogram or a CT or MRI, this is just in the beginning of especially these electric tests, is that pretty much it takes time for them to calibrate. And no, it's actually, and no, it's just they give it some time to calibrate before they actually start reading. You want your chocolate? Yeah, Sheikh. You answered it, you would have gotten your chocolate. But the electrocution person gets a chocolate, inshallah. Because that honestly made me laugh. Salah. طيب. طيب يا شباب. Now we're going to talk about the ischemia lecture. So the important concepts you guys should understand here, for example, are how do changes progress in ischemia? Like, what is the level of changes, for example, from this point to this point, or whatever. The difference between a STEMI and NSTEMI is also very important. The difference between a myocardial ST elevation and a non-myocardial myocardial infarction ST elevation. It's not that important because there are other things you can differentiate, but I'll tell you how to differentiate, for example, when we see an ST elevation in STEMI versus, for example, pericarditis or early repolarization. Localizing ischemia, I wrote it in here. So if you can't hear me, you can at least read. This is so important. Localizing ischemia, your questions will come from this. And then, for example, when do we do extra steps for identifying ischemia? طيب. ACS, we define it as basically acute coronary syndromes. It's one of the most common causes of death in the world. And STEMI in general is a medical emergency. You need to be able to identify it. And one of the ways which they do identify it is through the ECGs. In general, we have ischemia, injury, and infarction. This is how we differentiate acute coronary syndromes. But it's more important that you know this from the sake of the coronary artery disease lecture or the acute coronary syndromes lecture by Dr. Shamani, I think. Did he teach that lecture to you guys, by the way? Or was it someone different this year? The acute coronary syndromes lecture. Because I remember when he taught it to us, it's probably his most difficult lecture, but it was a very good lecture, Salah. I really enjoyed it. Like, In terms of ischemia, this is basically decreased perfusion in a certain area of the myocardium. It's the earliest manifestation of reduced blood flow. And yeah. So here, first of all, we have the normal heart rate. This is, alhamdulillah, this should be your heart rate right now. But let's say, for example, there is some sort of ischemia or or like less decreased perfusion because of ischemia. The first thing that happens is that you see this T wave, it flips. We call this a T wave inversion or a TWI. It's still symmetrical, but it inverts. And then after that, what happens is that the ST segment, which is this guy right here, it depresses, it goes down. At this point, when we see this ST depression with nothing else, this is when we could say that this is someone with subendocardial injury, meaning in the acute coronary syndromes, you have an angina, unstable angina. You have NSTEMI and STEMI. So I'm going to talk about them briefly, just so we're all on the same page. Angina or angina or whatever you want to call it. This usually happens when the vessel is 70% occluded for whatever reason. And when you exert, you feel chest pain. Unstable angina, this usually happens at 90% occlusion and beyond. And what happens is that even at rest, there's chest pain. There can be a non-ST elevation myocardial infarction. This basically means that there is an infarct here, but the vessel isn't completely occluded. And if we have that, we'll see ST segment depressions. In ST elevation MIs or STEMIs, what happens here is that the entire vessel is occluded. There's 100% occlusion. And that's why there's an ST elevation. So here, for example, this is defined as an ST elevation right here. And this is acute, somewhat reversible, depending on how quickly you can act. And yeah, this can happen anywhere from minutes to hours of the occlusion. And what happens is that this ST segment, rather than being down here, it actually goes up. We have these things called Q waves. Q waves, basically, they mean that someone may have had a myocardial infarction in the past. This can take anywhere from 12 to 24 hours to develop. So sometimes when they see like someone's regular ECG, you might see pathological Q waves, and they're very deep right here. And they last 0.04 seconds. How many small squares is this? 0.04? One small square, very good. And it's deeper than 25% of the R wave. That's one thing to keep in mind. And then, of course, they may be normal like this. This is a normal Q wave. It's small. It's very adorable. And it's less than 25% of the height of the R wave. So here they're showing you the different changes. First, you get the inverted T wave. After the inverted T wave, it can peak, but really we see this depression more. This is due to ischemia. So this you should have a proper T wave, but it inverts. Then we get this ST segment depression. After that, if it's complete occlusion, we can get this ST segment elevation. And then with time, eventually you'll get these pathological Q waves. The Q waves that are pathological, they're defined as being more than 25% of the height of the R wave. And they indicate that someone had a myocardial infarction in the past. These take 12 to 24 hours to develop. The ST segment that is in general, when we look at it physiologically speaking, this is the period between depolarization, which is a QRS, and repolarization, which is the T wave. So normally, the ST segment should be isoelectric. What happens, they're just showing you the graph, the action potential to relate it. So there's that. What happens in ST segment elevation is that it increases by one small square, which is 0.1 millivolts. So this right here, this point over here, I'll get a laser pointer because we do need to go in deep. This point right here is called the J point. The J point is the beginning of the ST segment. And what happens in ST elevation MI is that this J point, which lifts this whole entire thing, goes up by at least one small square. So at least 0.1 millivolts. So that's when we say we have an ST elevation and therefore an ST elevation MI. Over here, they're showing you the difference between subendocardial depression, injury, and transmural injury. Subendocardial just means that we have a lot of occlusion, but not complete occlusion. And as a result, there will be ST segment depression. With transmural, meaning the whole vessel is blocked, we'll have this ST elevation right here. This is important to remember. So with the, we have leads that are facing and then reciprocal leads. So one thing you should know about ECGs in general, or EKGs, whatever you want to call them, they're actually pictures or videos. Think of them as snaps. Like you take a snap of something and it shows you what's going on. What happens is that when something is going on in a certain area of leads, the opposite leads can have some certain activity. For example, if you have an ST elevation in one lead or a few leads, their reciprocal leads will actually have ST depression sometimes. It's not mandatory, but it can happen. So let's say we have an ST elevation in leads 2, 3, and AVF. The reciprocal leads, which are 1 and AVL, can have an ST depression. The opposite is true. If there's an ST depression here, there can be an ST elevation here. With anterior, for example, versus posterior. With posteriors, one of the ways you can tell is that you have ST depressions in V1, 2, 3, and 4. We don't really have posterior leads on the ECG itself. But there is a way to know that you're having posterior MI, and I'll talk about that later, inshallah. We'll get into that. So far, we're all clear? Great. 2 people have told me yes. I'll wait on a 3rd person. Great. 3 people have told me yes. Alhamdulillah. Okay. Inshallah, you guys are always clear about these things. So anyways, basically, like I said earlier, you need one small box is enough. One small box elevation in the J point is enough to say that we have an ST elevation. And again, the J point, it needs to be one small box above this isoelectric line. So the ST segment, as we mentioned earlier, it is in maflud, it's isoelectric to the baseline. What happens in an ST elevation MI is that it goes up by 0.1 millivolts or 1 small square. And this elevation needs to happen in at least 2 leads. Okay, someone asked a question. If you have depression V1, V2, V3, V4, how can you tell it's ischemia or anterior? Okay, I'll get into how do you tell an arteries late, but that's an amazing question. If I should explain that aslan when I get to localization. But if I don't answer your question, write this down. If you feel like I haven't answered it, or if you feel like you can't answer this question yourself confidently based off of what I explained, remind me. Does that sound fine? Because it's a very good question. Anyways, this ST elevation in general needs to happen in 2 or more leads. And they need to be in the same area. So for example, if you have an ST elevation in lead 1 and you have an ST elevation in V6, although they're both lateral leads, that doesn't necessarily mean that, for example, you have an ST elevation MI. They need to be adjacent leads or consecutive leads. So for example, and I'll show you guys when we get to the table. There's a table where we show you this. But the precordial leads, for example, V1, V2, if they both have an ST elevation, then yes, we consider this as an ST elevation MI in whatever area that is. Okay. Some important things to note is that pretty much 0.1 millivolts is enough in every lead besides V2 and V3. So here's where things start to get a little bit tricky. So if they give you a case, for example, with this elevation, for example, let's say they tell you it's a woman, or they tell you it's a man under 40 or a man over 40. I'm sorry, guys, give me 1 second. Sorry, guys. Anyways, as I was saying, in all the leads except for V2 and V3, 0.1 is enough, meaning 1 small square is enough. In the V2 and V3, if it's a woman, a small box and a half is enough. If the man is over 40, 2 small boxes is enough. If they're under 40, 2.5 small boxes is enough. If you need to remember anything about the J points, all the leads except for V2 and V3 need a J point above 1 to say that this is an ST elevation or a significant ST elevation. In V2 and V3, if it's think woman, man over 40, man under 40. If it's a woman, 1 small box and a half. Man over 40, 2 small boxes. Man under 40, 2.5 small boxes. So that's something you do need to remember. Because again, every small box counts in the ECG, especially for ST elevation MI. There are some other conditions, for example, new left bundle branch block, isolated posterior MI, and again, reciprocal ST depressions can help you determine if you have a MI in, for example, a posterior MI, but we'll get into that in more particularly. Like, you're probably gonna get confused here. Or Salah, I wouldn't blame you, because this idea of concave versus convex ST elevations is very confusing. They say convex is more likely to happen in acute myocardial infarction, and concave is more likely to happen in non-myocardial infarction events. Can anyone think of an example where we could have this concave ST elevation? Any diseases which can cause ST elevation but aren't MI? Okay, it's just pericarditis, not myopericarditis, but very good. I like the idea. And then yes, it is pericarditis. And we can also see this in an early repolarization, where we see something that looks like an ST elevation, but it's actually early repolarization. And I'll show you pictures of that, inshallah. There are all sorts of different ways in which an ST elevation can look. But the idea is that the J point, which is this thing right here, this thing right here, or this thing right here, and this thing right here, this should be above 0.1 in all the leads except for V2 and V3. V2 and V3, it depends on the no, don't be sorry. Relax. Look. Guys, one thing I want to mention is when you're answering questions, don't be afraid to get things wrong. You get them wrong now, don't get them wrong at the exam. Oh, it just shows I know you're thinking, which is nice. If I don't, be sorry. Relax. Thank you, guys. But anyways, in all the leads except for V2 and V3, a J point above 0.1 is good. Not good. It's enough to say that this is an ST elevation. And then if in V2, V3, if it's a woman, then we think 0.15, which is 1 small box and a half. If it's a man over 40, 2 small boxes. If it's a man under 40, we would say 2.5 small boxes. In terms of pericarditis, what is one other way besides looking at this convex and concave stuff, which is honestly very confusing? How could you tell with another thing that you have an ST elevation? What's another thing that could tell you that this is pericarditis? Like, what's another feature? Diffused, yeah, okay, diffused, very good. There's another feature as well. The diffuse that means many leads will have this ST elevation, maybe even all the leads, which is a very good point. But there's something else, which is the PR depression. The PR segments will be depressed in pericarditis patients. It's a good job. You guys got the diffuse part correct. Pathological Q wave, again, it can be over 0.04 seconds, and it's 25% or at least 25% the height of the R wave. There's basically, the reason this happens is, think about it this way. The positive activity goes toward you. Anything that goes up is positive, and this goes towards the electrode. So, and I'm doing this because I'm just pretending to be the electrode. What happens in these pathological Q waves is that no activity is happening because this tissue is dead. Because this tissue is dead, you won't really see, there won't be activity because it's infarcted. خلاص ماتت. But that's why you have this pathological Q wave. Yeah, that's pretty much it in terms of that. Here they're showing you the changes again. It shows you how does this Q wave develop over time. If it gets really severe between 24 to 72, or it gets really deep between 24 to 72 hours, and then after 2 to 8 weeks, it starts kind of normalize. Like, do you know what happens? This is a pathology question, but do you know what happens 2 to 8 weeks after myocardial infarction? Like, what process is going on? I know it's pathology and this is clinical, but it's nice to correlate them because at the end of the day, you're talking about the same organ and the same disease. Or you might be saving that lecture for right before the final for short-term memory. I do. Does anyone know what could happen from 2 to 8 weeks? All right, you guess. Hard if you say anything, honestly. Even if you want to say electrocution. Okay, can I repeat the question? Of course. Play. In 2 to 8 weeks after a myocardial infarction, what process is happening? In pathology. Fibrosis, very good. The scar is being formed. Yeah, scar formation, exactly. From 2 to 8 weeks, this is when the myocardial scar is being formed. ST elevation will go, QRS will be there. Kind of, but I'm just saying in terms of like, I know for me the thing I'm asking for is in terms of pathology, in terms of growth structure of the heart. What's happening is fibrosis from 2 to 8 weeks of that part that was infarcted. Play. Up till now, are we clear? Yes. One person has said yes. I need 2 more people to say yes. For pericarditis, where are the criteria mentioned? Okay. So you could go with the idea of concave versus convex ST elevation, which is fine if you understand it, but it's a little tricky because sometimes it will actually be convex, but it looks concave. The ways you can differentiate it, first of all, is that it will have pericarditis has ST elevations. They are diffuse ST elevations, meaning they happen in all of the leads or many of the leads. And the other thing about them is that the PR segments will be depressed. That's another thing with them. Does that answer your question? Of course. All right, great. Let's move forward. Okay. This is where we start to get to some very, very important slides, which is how do we localize an infarction? Oh, I can't stress how important this is. I will repeat this for as long as you guys need. But if there's any part which I think is super important to pay attention to, if you understand just the fact that the J point should be above 0.1, except for V2 and V3, which should be higher, and then I just want you to pay attention to this, you've understood a very big portion of where I think they will ask you guys questions, because that's where they ask us questions. Like, different leads refer to different parts of the heart. And I wanted to save this, instead of yesterday, I wanted to save it for today. So V1 and V2 are septal. So they refer to the septum of the heart, the intraventricular septum. V3 and V4 refer to the anterior portion of the heart. The lateral portion of the heart is represented by V5 and V6. Now, we can say that a myocardial infarction is anteroseptal, or we can say that the anteroseptal area is V1, V2, V3, and V4. طيب. We can say anterolateral is V3, V4, V5, V6. And then we can say extensive anterior is 1, 2, 3, 4, 5, and 6. طيب. Meaning refers to the entire anterior of the part. So we have anterior, we have septal, and lateral. And if all of these leads have an ST elevation, this is an extensive anterior ST elevation MI. The inferior leads, they're represented by leads 2, 3, and AVF. And then the high lateral leads are represented by 1 and AVL. Now, posterior, one of the ways in which we can identify a posterior myocardial infarction is we have no ST elevations, but we have ST depressions and tau R waves in V1 and V2. So it looks like an upside down ST elevation in these leads. Now, these leads are reciprocal to the posterior. So as a result, we have a good reason to suspect that this indicates that there is a posterior MI. But there's another way which we can tell. Does anyone have any idea what leads we can check to say, okay, we think that there could be a posterior MI? So let me repeat the question. We can tell that there's a posterior MI if there are ST depressions in V1 and V2. It's a good reason to suspect that we have a posterior MI with these leads having ST depressions. There is another set of leads which we can also suspect that there could be an ST elevation MI posteriorly. But does anyone know what leads there are? What leads can tell us that or can indicate that? 3 AVF, very good. There's one more lead. Not V3, 3 in AVF. طيب. What else? There's one more lead. So 3 in AVF. What else? Two. Yeah, lead 2. So 2, 3 AVF, the inferior leads, they give, if they have an ST elevation, this gives us good reason to investigate if there's a posterior myocardial infarction. The reason being is when we go, oh wait, they're going to ask you guys a question, but the reason, well, and I'll show you guys a table, but leads 2, 3, and AVF, they actually represent the right main coronary artery, which also supplies the posterior of the heart. So you're going to need to be familiar with your anatomy and what parts of the heart are represented by which arteries. Because again, and this is ECGs, while you may think that they're functional, but they're also very structural. They can tell you a lot about the structure of the heart. Wait, here's a practice question. So this is a 68-year-old woman with chest pain. And what is the diagnosis? You're not, like, I don't know if you remember the picture I showed you guys in the beginning of how I approach, but all of the options here have something to do with ST elevation. So they say pericarditis, early polarization, and then myocardial infarction. So I'm not looking for wala tachyarrhythmia, wala bundle branch block, wala a shay. I'm looking for ST elevations, and if I don't see any, ST depressions. Can anyone try guess the diagnosis here? And I can zoom in. If anyone wants me to zoom in on a few leads, I can do that, because you need to look closely and see what's going on. Okay, so someone said anterior septal, someone said B, another person said B. So why do you guys think it's B? And if you think it's anterior septal, why do you think it's anterior septal? I'm not going to say if any of you guys are right, because you may both be wrong. But you never know. Why do you think it's anterior septal? 1 AVL, high lateral. Okay, but you said, but B is anterior lateral. So ST elevation in V1, 4. Okay. V1 and 2 are anterior. Okay. So it seems like we're all a little bit confused, which is fine. It happens. But if we take a closer look, for example, let's take a look over here. So first of all, we see these very prominent ST elevations in, so V1 does look like it does have an ST elevation, because it's not, the ST segment isn't isoelectric. V2, it does look, again, there is an ST elevation, it's pretty prominent here. 3 has a prominent ST elevation, 4 has a prominent ST elevation, 5 has a prominent ST elevation, V6 has a prominent ST elevation, 2, 3, and AVF don't. AVL has a slight ST elevation, same thing with lead 1. So honestly, if there weren't options here, I'd probably say that this is extensive anterior. But because there are options, the closest thing would probably be, or is this pericarditis? No, it's not pericarditis. The reason being 2, 3 AVF don't have ST elevations. And you have very good reason to suspect that this is MI. But let's see, maybe you could be. But this is anterior lateral. Now, I know what you're thinking, like 1 and V2 look elevated. And I agree with you guys. To me, in my opinion, I think these are ST elevations. But actually, what we're looking at here, it can be confusing sometimes. So I would say, for example, if there were no options, I would say that this is extensive anterior, because I think that all of these leads are elevated. The anterior leads, the septal leads, the lateral leads, the high lateral, they all have ST elevations. But really, what you need to understand about the way our exams work is that they ask you what is the most likely. The most likely and the most correct answer would be anterolateral, but it is anteroseptal in my opinion. But I apologize if this does seem confusing. But just looking at this picture, I would say it's anteroseptal, and I would not disagree with anyone that's extensive anterior, and I wouldn't disagree with anyone that says it's extensive anterior. But for some reason, it says anterolateral. BLCs, if you're listening to this, if you get a question that's like this, make sure you appeal if they say the other option's wrong. Okay. Now you need to understand what main arteries, for example, supply what. So left anterior descending, or actually, I don't like this picture. Or this is important, but I don't like this. There's another one I prefer. Oh, okay. They want to ask you guys. I'll get to the questions later, but there's a table I want to go to. This one right here. Okay. So, and if we take a look at this, for example, this is, so I don't know if you guys remember brainstem, but there's a rule of fours there. Here, there's also what I call it a rule of fours, but you can call it whatever you want. The reason being is that 4 leads represents 1 artery, kind of. Starting off with lead 1. Lead 1, AVL, V5, and V6, they all represent the circumflex artery. V1, V2, V3, and V4 represent the left anterior descending. 2, 3, AVF represent the right coronary. AVR does not represent anything on this picture, but do you guys think it can represent something? Do you think if we have an ST elevation in AVR, do you think it could represent something, or does that just mean the ECG is wrong if AVR has an elevation? What do you guys think? Like, I don't know if you noticed, but we never mentioned AVR for any sorts of these leads in general. Like, for example, we never mentioned it for anterior with a septal, with an anteroseptal, with a whatever. Reciprocal, not exactly. It's not exact, it would not be reciprocal because it doesn't, again, from the things we've mentioned, we've covered all the aspects of the heart except for the posterior, and AVR does not represent posterior. Actually, I had to read online to figure out what it does. And apparently AVR, it's debated upon, but what happens is that if AVR has an ST elevation, the entire left main coronary artery is blocked rather than its branches. This would be blocked, theoretically speaking. Now, you don't need to know that for the sake of exams, but I just thought it was interesting to mention in case anyone thought of that as a question, if we have an elevation AVR. But, wait, let me go back to that picture because it is important. Screenshot this, be familiar with this, and memorize this. So think about it, 4 arteries, 4 leads represents 1 artery, except for AVR. AVR does not represent an artery for our level of knowledge. V1, V2, V3, V4 for left anterior descending. 1, AVL, V5, V6 for circumflex. 2, 3, AVF for right coronary. But please be familiar with that. Wait. Here, they're talking about what does each thing supply. So the left anterior descending, so this is mainly what we need to know, but it mainly supplies the anterior wall. It supplies the septum as well. So yeah, and with the circumflex artery, for example, in some people, it does supply the SA node, and it supplies a small part of the posterior wall. But if we're thinking posterior wall, we should really think the inferior nodes. Because they're supplied by the inferior electrodes, because they're supplied by a right coronary artery. And they're just showing you the different types of STEMIs in different arteries, but yeah. Okay, let's practice with this one. Play it. Here, where do you see ST elevations and what would you call this? Also, if anyone's watching the recording eventually, you can pause until we answer. Okay, V2, V3, V4, V5, play it. V2, V3, V4, V5. Anyone else? V6 also? Okay. 1 in AVL also, play it. Okay, let's take a look. All right. Let's start off with lead 2. V2, okay? So for example, do we think that this is an ST elevation in V2? Yes or no? So this is the isoelectric line, and this is the J points. Or actually, the J point's right here, really. So is this an ST elevation or not? This is the isoelectric line. This is the J points. It's not an ST elevation. The reason being, in V2 and V3, the ST elevation needs to be above, at least, they didn't give us a scenario here, but needs to be above at least a small box and a half, assuming whatever reason. So this isn't a significant ST elevation. Actually, it's quite small, really. V2 is not elevated. V3, is there an ST elevation? Yes or no? Yes. Okay, here there is. It's more than one. Again, it's kind of more than a box, but look, this is the isoelectric line right here. And the J point looks like it's around here or here. But it's around a box exactly. But it's still less than a box and a half. But yeah, V3 is elevated. V4, isoelectric line. This is the J point. Is there an elevation in V4? Yes, there is. V5? So V3, V4, V5 so far, yes, we're at V3, V4, V5. What about V6? Do you guys think there's an ST elevation here? This is the isoelectric line, this is the J point. Yeah, so this is an ST elevation. We can look at lead one as well. Lead one, do you guys think this is an ST elevation? The J point's right here. Is this an ST elevation? Yes, it is. And AVL right here. Is this an ST elevation? Yes. So V3, V4, V5, V6, 1 and AVL have an ST elevation. So what do you guys think this is? Anterior lateral. Let's see if you guys are correct. Extensive anterior lateral, but it's either way, it's anterior lateral. Very good, guys. Good job. We solved this correctly, alhamdulillah. طيب. This one. So I'll give you guys a minute to try solve it. Any guesses so far? Okay, so someone says lateral. Do you guys agree or disagree? If you think it's lateral, what leads do you think have an ST elevation? One AVL have an ST elevation. Very good. What about the other leads? V5 and V6 as well. Very good. So this is a lateral myocardial infarction. Very good. Here, they're showing you a 55-year-old man presents with chest pain. Is this acute anterior, acute septal, acute anterior, acute inferior MI, or lateral wall ischemia? What do you guys think? C? Do you guys agree with C? Very good. Yeah. Let's see if you guys are correct. It is acute inferior. Good job, guys. طيب. What artery supplies these leads? What artery do these leads represent? Right coronary artery. You're absolutely correct. MashaAllah alaykum. Okay, yeah. This is important to remember. So most likely the SA node and the AV node will be affected in a right coronary artery, myocardial infarction. Also, they supply the inferior and posterior portions. But because it supplies this, that's why when we have an inferior MI, we should try rule out a posterior MI as well. The indications for doing so, for example, would be that we have an inferior MI in the first place. And then let's say, for example, we have a ST depression in V1, V2, we should check to see if there's a posterior MI. Here, do you guys think that there could be a posterior? Do we have enough reason to check if there's a posterior MI? Yes or no? And why? Did you guys understand my question? Well, just to repeat, so basically, if we have an inferior MI and or ST depressions in V1 and V2, do we have enough reason to check for a posterior MI? Yeah, okay, so we have the inferior MI. That's enough reason to say, yeah, it's reciprocal, absolutely. For here, we have this idea, and no, the reciprocal, we should check to see if it's a posterior MI. For we already have 2-3 AVF. For these, having an elevation is enough reason alone to go check if there's a posterior MI. But having V1 and V2 depression here, that also helps. So we should check if there's a posterior MI. طيب. Do you guys know how we check? So here are the options for checking. And no, we don't do any of these. So someone said A. Do you guys agree with A? Do you think it's B? Do you think it's C? Okay, when do we check for posterior? Played. It is C. Right side in ECG and 15-leader ECG are the same. Like, when should we check for a posterior MI? Played. First of all, just so we're all on the same page, the posterior parts of the heart is supplied by the right coronary artery. The right coronary artery is represented by leads 2, 3, and AVF. So when we have an infarction here, that means we have an inferior myocardial infarction, meaning the right coronary artery is blocked. If this is blocked, that means that the posterior part of the heart, which is more advanced in terms of the artery course, that part might be affected. So let's say we have an ST elevation in 2, 3, and AVF. That's one of the reasons why we might check for a posterior MI, because it supplies the same artery. The other reason is that V1 and V2 are the reciprocal leads to the posterior parts of the heart. So if we have an ST depression here, there's a good chance in the posterior, let's say we did check the posterior, there might be a complete occlusion of the right coronary artery there. So either we have ST elevations in 2, 3, and AVF, or we have ST depressions in V1 and V2, or both. That's when we check for posterior. Does that answer your question? Alhamdulillah. طيب. And what we do is it's either called 15-lead ECG or a right-sided ECG, and that's how we check. And the extra leads we get are V7, V8, and V9. So yeah, here they're showing you true posterior, right ventricular, whatever. Yeah, so here, for example, we have ST depressions over here. This doesn't necessarily look like an ST elevation. Like, it's only one of the leads that looks like it has an actual ST elevation. But we have ST depression in V1 and V2. And as a result, khalas, we have enough reason. Let's check if it's posterior. For this is where they put the leads. So the V7 is at the left posterior axillary line. V8 is at the left tip of the scapula. And V9 is at the paraspinal region. I don't think they've asked us any questions about the posterior leads. Just in case, good to know. So yeah, we see these ST depressions over here. The reciprocal will have the ST elevation. And I even saw that, for example, another way of thinking about this is imagine the ECG is upside down here. So that's why we check posterior, where it'll be right side up. So yeah, here we see a right ventricular or a posterior MI, and that's enough reason to suspect, and we need to check the posterior, which are V6, V7, V8, and V9. Up till now, are we clear? Any questions so far? This is the last part of the lecture for the previous ECGs. Okay, which previous ECGs? Start off with this one, I think. I see ST elevations everywhere. Like, I can't tell. Okay. So I think I know which one you're talking about. I think you're talking about this one, right? Okay. So I can understand why you'd think that there are ST elevations everywhere. But if you just look at 2, 3, and AVF, they don't have ST elevations. You see? There's no ST elevation here. There's no ST elevation here. There's actually ST depression in 3 and AVF. The one after, I'll go to that one as well. But really, you just need to look at all the leads. But I completely understand why you would think that. Look, you need to practice ECGs in general, which is why I put a bunch of practice questions. Going on websites and practicing, for example, is another good way to just familiarize what is an ST elevation, what isn't. But if you look here, there isn't an ST elevation. But I can completely understand why you'd think that. This one you're talking about? Are you talking about this ECG? Okay. There is an ST elevation in V6. Look, this is the isoelectric line right here. For the J point's right here. For that is a very, it's an ST elevation. If we look at, for example, 2 has an ST depression. No, it's normal. 3 has an ST depression. AVF has an ST depression. So you just need to look very closely. This is the QRS. This is the isoelectric line. This is the ST segment. But there's no ST elevation. V6 elevation. The previous ECG, there is V6 elevation. Let's see that. Yeah, there is. I agree with you guys. Right here. That's ST elevation. All right, sorry. This one right here. This is ST elevation right here. I agree with you guys. Oh, we agreed. And no, this isn't. This probably is actually anterior. Is extensive anterior, not anterolateral. But we did agree. And no, there is an ST elevation in V6. But good for pointing that out. Wait. Besides those, are we clear? Alhamdulillah. Okay. Let's move on to this. So here it's just practice, all right? And I'm going to tell you one thing. You're going to get this question wrong because it wasn't explained yet. I want you to try. What do you think this could be? Even if you get it wrong, I want you to tell me what it looks like or what you would assume that this would be. Like this one, I'm 99% sure that this one you guys will get wrong. But that's fine because I got it wrong when I first did it too. And yes, there are ST elevations here. But how about tell me where the ST elevations are? It looks concave. Okay. It is concave. You're right. V2, V3, V4. Yeah, it's V2, V3, V4. That's where we have the ST elevations. But just to zoom in, just to confirm, one's a little weird, but it doesn't have. It's barely even a square. It's not significant. 2 has. 3 has. It's not 4. 4 has. It's kind of minute, but it does have. It's right here, technically. 5 doesn't really have, it's barely even a square. Because it's actually more like half a square, to be honest. Hatta 6, it's, again, barely even a square, it's half a square. Based on this, because V2, V3, and V4 are elevated, what do you think this will be? What would you assume that this would be? Is this pathology or physiological? It's pathological. Okay, good. So just looking at this, you would say that it's anterior, but I'm going to tell you guys that it's not actually an anterior stem. Actually, this is what we call early repolarization. Now, I know what you're thinking. You're confused as hell. And believe me, it is confusing. But the one thing I want you guys to look at is if you see here, it's a curve before the actual ST elevation or the ST segment. This right here is the ST segment. This is a repolarization that's early. It's not supposed to happen, but it's there. And this is pathological. So if you see this bump over here in some of the leads, this means we have early repolarization. Normally, it would not have this bump. Normally, it just either just curves or it's flat or whatever, but it doesn't have this bump. This bump right here is how we know we're looking at an early repolarization. And one of your colleagues said it's concave. That's another way of looking at it. If you like the concave convex system, that works for you. Great, because it is concave. If you look at here, for example, like I'll draw the line. So I don't like the concave convex. So if you draw the line, it's concave. I know this is a terrible line, but just bear with me for a moment. But this is an early repolarization, but really we tell it from this bump. Also, if you're good with the concave convex, you can also be familiarized yourself and know, okay, it's a concave ST elevation. Let me make sure this isn't an MI. So you'll check all the leads, see is this diffuse ST elevations or not. Yeah, this is early repolarization. It is an ST elevation, but not because of a myocardial infarction. It's a bump. But this is due to early repolarization, and it is pathological. Here, what do you guys think this could be? It's almost all the leads. Very good. It is almost all the leads. What do we call that? Pericarditis. Pericarditis. MashaAllah alaykum. Now I know what you're thinking. You're probably going to look at, for example, the inferior leads. For this one, this one does look like an ST elevation. This doesn't really, but if you see here, we have PR depression. You need diffuse ST elevations, meaning the ST segment needs to be elevated in almost all of the leads, and the PR segment should be depressed. So this is pericarditis. Very good, guys. There's another clinical lecture for that. So yeah, sometimes early polarization can be benign, but it's not something normal in general. And yeah, if it's ischemic, it should be convex. If it's not ischemic, usually it's concave. Other causes, here are some different features. For example, how elevated is it, the morphology, concave versus convex, and other features as well. That's usually how I would differentiate it. Like here, what do you think this patient's having? All right, someone said non-STEMI. Okay, is it acute? Because of the ST depression? Yeah, it is acute. You're right. There is ST depression, and this is not STEM. Very good. Now I know what you got. Now something you guys might think, for example, but V1 isn't isn't a T wave inversion, but here we see T wave inversions. See this? It's very peaked, and it's very inverted. So this is a T wave inversion. V1 doesn't have a T wave inversion, and it doesn't have an ST segment depression either. We're not going to really think that this is posterior. Actually, this is an N-STEMI. Eventually, for example, like when you get to the clinics, inshallah, or even if you do end up pursuing cardiology, you'll figure out like when do we know if it's posterior or not. But this is just end-STEMI. You don't need to localize end-STEMIs, by the way. Like I don't think they've ever asked, for example, is this a STEMI or end-STEMI? But you could say it's anterior lateral end-STEMI. You would not be incorrect. You'd actually be very correct. But yeah, very good, guys. Like here. Loss of consciousness is LOC. 70-year-old man with decreased loss of consciousness. Interesting. Okay. What do you guys think? Okay, someone says anterior lateral. Okay. If you think anterior lateral, why? What leads do you see that are elevated? One AVL, V2, V5. All right. So, okay. V2 and V3. This is a 70-year-old man. How much should the ST elevation, how many small boxes should the J points be above in a 70-year-old man? How high should the J points be? In a 70-year-old man, 1.5 is if it's a woman. In a 70-year-old man, it's 2 small boxes. Like, what about a man under 40? How many small boxes? 2.5. Very good. For here, this is around 2. So yeah, this is an ST elevation. This is above 2, ST elevation. ST elevation, ST elevation. Let's see if you guys are correct. Oh wait, they didn't mention. Okay, well, you guys are correct. You never know when it's going to answer or not, but you guys are correct. Can I abshir? V6. V6, it's by one. You can barely notice it. It's very subtle, but it is around 1. But even if if you don't think it's elevated, look at lead 1. Lead 1 is elevated. AVL is elevated. This should be anterior lateral. Oh, it said anterior lateral. Okay, good. You guys were covering it. It's not you guys' fault. Okay, anyways, let's look at this one. Okay, 70-year-old woman. If you're looking for ST elevations in V2 and V3, how many small boxes should it be? 1.5. Very good. Now, what kind of myocardial infarction? If she has a myocardial infarction, of course. What kind do you think she has? No, she doesn't have a myocardial infarction. What do you think she has? Anterior. Okay. If you're saying anterior, tell me what leads you to see elevated. V3 to V4 for anterior. Okay, someone's saying anterior septal. If you're saying anterior septal, why? V2 is elevated as well. Very good. V2 and V5 are elevated. V3, V4, V5. One thing I want you guys to remember, when we say in no, we have, for example, anterior or anterior septal or whatever, in the 2 plus leads need to be confirmed. So to say that this is septal, for example, we need to say in V1 and V2 are elevated. If we're going to say lateral, we need to say V5 and V6 need to be elevated. So we need 2 plus leads to confirm. And they need to be consecutive. For example, is there an ST elevation in V1? V1, is there an ST elevation? No, there isn't. So we can't, Aslan septal is out of the picture at that point. We see V3 is elevated. V2 is elevated. I agree with you guys. V3 is elevated. V4 is elevated. V5 is elevated. V6 Doesn't really look elevated, but it could be. But in general, the answer here would be anterior. For whoever said anterior, very good. We can, oh yeah, exactly. V3 and V4 are the only two leads which both have their own area that they represent. They're consecutive and they both have ST elevations. So as a result, we can only say this is anterior. We can't say anterior septal. We can't say great extensive anterior. We can't say anterior lateral because V6 is not elevated. And if you look, you can tell it's not elevated. If you want to confirm lateral, one is not elevated, AVL is not elevated. Saadi, it's good that I'm very happy that you guys are making mistakes now. Ashan, if you're going to make them now, you won't forget them. What's the difference between this one and the previous one? Because the V6 previous one. Okay, very good. Lateral, we can confirm it through two leads, through two areas, V5 and V6, or one in AVL. But in the previous ECG, which I'll show you guys now, these two were elevated. This one doesn't look that elevated, but V5 is elevated. So we say this is anterior lateral because of one and AVL. Does that answer your question? Because the anterior and lateral leads are elevated. Because again, one and AVL, by the way, are considered consecutive. Okay, this one right here. Oh, okay, answers. So if one, yes, we can. If one and AVL are elevated, we can consider them enough for lateral. You're absolutely correct. This one's a little bit tricky, so you got to keep your eyes open. Anterior lateral. Okay, you're saying anterior lateral. Do you agree? If you say anterior lateral, why do you say it? Also, 55-year-old man, if you're looking for ST elevations V2, V3, what does how many small squares? Someone's saying inferior. Okay. How many small squares does it need to be to have an ST elevation in V2 and V3? 2. Yes, he's a 55-year-old man. So it needs to be 2 small squares. So let's look at 2 and 3, first of all. Is there an ST elevation in lead 3? No, there isn't. Hatta without the rule, and we need 2 small boxes, there is no ST elevation. Wala and 2. If you look at V4, there kind of is some elevation. I can see that. 5 and 6, do you guys think they're elevated? Okay, you guys think 5 and 6 might be elevated. What about 2, 3, and AVF? 2, 3, and AVF look elevated. What about 1 and AVL? Do they seem elevated to you guys? No, they don't seem that elevated. Okay. So we have leads 2, 3, AVF, and we think that 5 and 6 might be elevated. What do you guys think is going on? What's your final answer? What's your verdict? Inferior lateral, interesting. No, I don't think an inferior lateral infarction can happen. It's inferior. Like, now you're probably thinking, okay, how is it inferior? Well, the reason we can say this, for example, is we have to look at the evidence that supports this. So there can't be a true STEMI in both of these. Oh, I know you got. Why did we ditch V5 and V6? Okay. Why did we do that? It's a good question. So if you look at it this way, right? One of the ways you could think about it, if we just want to keep it simple, and the more of the 100% of the inferior leads are elevated, and 50% of the lateral leads are elevated. But that's not enough. That's just we're saying in our head. On the exam, that's probably what we're gonna think. But if you look at leads 2 and 3, or even 2, you can see a very subtle, actually, ST depression, حتى. It's very subtle, but you can kind of see that. حتى in V3. We don't really see in V4, we don't see in V5, we don't see in V6. But it's very subtle, but there's a slight ST depression. And because it's reciprocal, 2, 3, and AVF are what we're looking at. I know it can be confusing, believe me, but you're going to have to trust the science on this. But yeah, because like, look, even this, for example, it's 2 boxes. It's around 2 boxes. Had to hear it's around 2 boxes. See? Maybe a box, but still, it's not that. I can completely agree why, I can see why you'd say, no, we look at, we call it lateral. Play it. Oh, okay, here they told you. So they're saying inferior and posterior. Do you guys agree? And why? Besides the fact that the doctor wrote that it's inferior and posterior. You don't need to check the other ST elevations. I said inferior and posterior. Why? Why would they say inferior? Why would they say posterior? V1 to V3 depressed. Even V4 is depressed, by the way, but very good. So yeah. So here, 2, 3, and AVF have elevations. V1, V2, and V3 have depression. So we need to check posterior. We can't just say it's posterior without checking, but we have a lot of huge reason to suggest, and then we have a posterior myocardial infarction. How do we check? Like how can we be sure? What do we do? 15 lead ECG. MashaAllah alaykum. Very good. We do a 15 lead. So here they're showing you guys the 15 lead. So this is V4, V7, V8, and V9. Do they have ST elevations? Yes or no? Are 7, 8, and 9 ST? Yes, they are. Okay. Okay, here's a pharma/clinical question. What drug is contraindicated in this kind of myocardial infarction? If you guys know. You get this ECG, they want management, but there's one drug that's contraindicated in this kind of myocardial infarction. The digoxin, not the digoxin, look for something else. Think specifically this, which you would give for other types of myocardial infarction. I should have specified that. But just to repeat the question, yes, nitrates. Nitrates, you can't give nitrates in inferior myocardial infarctions. They worsen them, and it says so in your clinical lecture. But do remember that, because that's a very good place for them to ask questions if they want to like combine the lectures and give you guys something. It's a very good opportunity for them. Like here, 67-year-old lady with diabetes mellitus and hypertension. They put this to throw you guys off. I'm telling you this, but it's good that they're bringing this back, because I'm sure that we mentioned it and you guys forgot it. May Allah have mercy. Ameen ya Rabb. Like, do you guys know what could be going wrong? It looks normal. You're right. It does look normal, but it's not. Old am I. Thank you so much. Khalas, and you deserve a chocolate tomorrow, inshallah. But yes, this is an old myocardial infarction. How do we know? Look at this right here. Pathological Q waves. They're so deep. Yeah, exactly. Right? You genuinely, it's very funny when you just look at this. But this is an old anterior septal. How do you know this is anterior septal? V1 has a pathological Q wave. V2, V3, V4 has a pathological Q wave. So this is anterior septal. And how do we know it's anterior septal? The Q wave should be at least 25% the height of the R wave. Like here. There's a lot of practice. Hatta and I have practice after this too. Allah yankum. 50-year-old man with chest pain. It's normal send normal send home. Are you sure? What? How about we just make this a freebie? Oh wait, someone said V5 looks like a pathological Q. Let's see. No, I wouldn't agree with you. I'm sorry. I don't agree with you. V5 doesn't have a pathological Q, but actually the Q looks normal here. It looks cute. But let's give this one away. Old inferior. You guys ignored these right here. But yeah, all of the inferior leads have this pathological Q wave. This is normal. This is normal. This is normal. This is actually the R wave, not the Q wave. If you look here, for example, though, like this is the Q, this is the R, this is the S. The Q is massive. Saadi, how often? Oh my God, so many questions. But it's good to have all these questions because you never know. Okay. He presented the ER with chest pain, elevated CKMD, and troponin. What do you guys think he has? Non-STEMI. Okay, let's see. You guys are correct. Yeah, Allah, so many. How many more? Oh, okay. This is the last one. I gave it away. It's early repolarization. But can someone tell me how I can tell this is an early repolarization? Like, what's the key here? And I'll zoom in a little bit more just so you guys can see. The bump, the little bump right here. The boo-boo. All right. Then here are some practice ECGs I brought. But we've done a lot of practice. But I still think it's good to practice. I want you guys to tell me what you think is going on your own time. This is practice for you on your own time. So I will just stay a bit. If you feel like answering, go ahead. But because we practice a lot, I think it's good if we just like have these for the YouTube people and yourselves. Oh, and I can just send the answers to your batch, or you can just check the comment section because I've sent the slides. You guys should check the comment section. And if you disagree, tell me why. طيب. Okay. You know what? I like this question. So I'm only going to ask this one. طيب. Who can answer this? And I just want you to tell me the answer. By now, you guys should know why the answer you say is the answer. This might actually have been taken from one of the past slides. Inferior MI. Good. طيب. What's the next step? We see inferior MI. What's our next step? 15 lead, just in case there's posterior. Very good. طيب. This was honestly just a fun fact. I don't expect you guys to know this, but I put it there anyways, the explanation. Okay. That's it for the ischemia. We took some time with that, I know, and I apologize, but you guys have a break because I need the break too. Just before I begin, I think yesterday I might have misspoken about something with PR. So just in case, and the reason I'm putting this on recording on purpose. So in terms of the P wave itself, it should be anywhere from 0.06 millisecond, 0.06 seconds to 0.1 second. So that's that is 1.5 small boxes, 2.5 small boxes. The PR, I believe I said that correctly, which was that it's 0.12 to 0.2. So that's 3 to 5 small boxes. So that just in case I misspoke yesterday. Anyways, and here we're going to talk about the chamber abnormalities. So in terms of the heart, for example, you guys have probably taken something about cardiomyopathies, maybe. You probably took like dilated cardiomyopathy versus hypertrophic, and we're kind of going to see something along those lines here. For really, we need to just understand one thing. In terms of the atria is not a very like thick chamber. It's actually quite thin. So what happens is that when the atria gets bigger, it dilates or it enlarges, and usually this is stretching. With the ventricles, what happens is usually it will actually hypertrophy, meaning the muscle will increase in thickness. So in dilation, this usually happens because of some volume overload, whereas with hypertrophy, it's due to pressure overload. But that's just something to keep in mind. Also, just to recap, the atria, in like my way of thinking about it, it's the P wave. The atria is represented by the P wave. But if we have atrial enlargement, something is going to happen with the P wave. It's actually going to increase in size, or it's going to increase in amplitude. The reason being is that if the atria gets longer or larger, the cardiac conducting system within it is by default going to have to get larger. And if the circuit is longer, the time it takes for the current to pass through the circuit is going to take longer by definition. Like if there's more circuit, there's more time to pass through the circuit itself. So as a result, we expect an increase. My hypertrophy, the ventricles themselves, I usually think of them as a QRS. So we expect the QRS to get larger. And because, again, there's a lot of, there's a huge electrical system within the ventricles. As a result, if the ventricles increase in size or increase in muscle, the electrical activity, the electrical conducting system needs to increase as a result. So that's something to keep in mind. This is dilation, this is hypertrophy. Okay. So yeah, we've mentioned this. P wave for the atria, QRS for the ventricles. So here, I don't expect you guys to know what this is, but I want you guys to tell me, what do you see in this P wave right here? And I'm going to zoom in for you guys. So what do you see? Mitral, okay, mashallah. Okay, you know it. But what does it, just tell me what it looks like, very simply. Does it look normal? 2 bumps. Looks like an M, 2 bumps, exactly. This is called mitrali, you are correct, mashallah. But just simply, this looks like 2 bumps. And we're looking at lead 2. So in general, with the atria, we need to look at 2 leads. Lead 2 and V1. That's usually how we can tell if there's atrial enlargement and which atria is enlarged. So here we have mitrali. So one thing to understand about the atria is that this P right here, this is formed by the activity of both the left and right atria. So it looks like this. So really, there's a picture that shows you guys their activity. So we'll get to that in a bit. But pretty much, like I said, we use leads 2 and V1. The first parts, so the left half, or right here, let's divide this in half. This part represents the right. This part represents the left, because the right is going to be depolarized before the left. And we expect, they're going to combine. So let's say we have enlargement. What normally happens is that these two will be in sync. In enlargement, they separate more. That's why we get this notch right here. If you guys can see that. Like we said earlier, the normal P wave is less than 2.5 millimeters tall. That's something important to remember. And 3 millimeters wide. So the P wave should not be more than 3 millimeters. If it's beyond, some people say 0.12, some people say 0.10. In case you want clarification, just make sure you confirm with Dr. Banda. And yeah, there's that. So pretty much what happens is that in lead 2, in left atrial enlargements, we will see this mitrali. And in lead, in V1, we'll actually see increased amplitude of V1. What does that mean? So what we see in V1 is this appearance right here. So this half represents the right, and this half represents the left, because the right is depolarized before the left. What will happen is that in V1, if left atrial enlargements, because the left atrium size will increase, this amplitude of this part right here, just this part, will increase. which we can see here, kind of. So this is the whole P wave, and this part is the left atrium. So it takes the left atrium has to depolarize more because there's more left atrium to be depolarized. As a result, that's why it has that appearance. Like it. So yeah, there's more, again, more force, more stuff is needed to go through. Okay. So the P wave needs to be beyond 0.12 seconds. Lead to it, what's it called? They're telling you in no, the distance between the notched peaks needs to be above 0.04 seconds. So it needs to be above one small box. So my mitrally right here, which we see in lead 2, the distance between this peak and this peak should be more than a small box, which it is. I know it doesn't show that clearly, but that's what it looks like. And as you can see, again, in left atrial enlargements, we have the P wave right here. Let me draw it just in case. Oh, no, it doesn't let me zoom in. But, you know what, wait, 1 second. Okay, let me draw what it should normally look. So right here, this is the right, and this is the left. So what happens is that the amplitude, the left side is increased in amplitude. Normally it should just be this, with this very small notch right here. But yeah, so what happens in left atrial enlargement, this is in V1, is that we have this increase in amplitude of this side. With lead 2, what we see is mitrally. And the distance between the mitrally needs to be at least a small box. So the distance between this peak and this peak needs to be more than a small box, which is 0.04 seconds. Yeah. Does that make sense? Like, I hope I didn't lose you guys already, but does that make some sense? Okay, good. Like, here they're showing you. Finally, there are all sorts of causes. It's good to be familiar with these causes. This can happen because of left ventricular hypertrophy. Why? In the left ventricles, this will happen because there's increased pressure. And if you guys are familiar with pressure gradients, for example, fluids will go from high pressure to low pressure. So the pressure is lower in the atria than the ventricles, and especially during hypertrophy. In hypertrophy, it's a lot higher than the left ventricular pressure is a lot higher than normal. As a result, the fluid is going to build up here. And when the fluid builds up here, the veins have valves. So they're not going to allow the fluid to go back into the lungs. What will happen instead is that this atrium will actually dilate. But it's actually a mechanism to kind of bypass this, to not explode. It actually dilates. This can happen because of mitral stenosis. Mitral stenosis, why? Blood cannot flow through, or it's a much harder time flowing through. So as a result, the atrium enlarged. Regurgitation, the blood keeps flowing back into the left atrium. They're just showing you different causes, but it really makes sense. You just have to think, okay, what is wrong with the structure? What happens as a result? That's essentially what they're trying to show you. If you understand the basics of blood flow, you can understand why left atrial enlargement happens. Yeah, and if there's a cause here that doesn't make sense, let me explain it to you, because that's what I'm here for. Is there a cause here that doesn't make sense? Or something that you're not exactly sure? Hypertension is associated with hypertrophy. Aortic stenosis, again, it makes sense because blood can go here, it goes back. Deficiency, same idea. I think it all makes sense, but let's move on. Like here, what do you see that's abnormal? لا حد يقول لي pulmonary. No, tell me what's actually like seen. Tall P waves. Very good. Yes, tall P waves. Do you understand why the P waves need to be tall in this case? Like, don't tell me like, oh, it's the right or the left that's affected, but why is the P wave tall? I mean, from your understanding. That's if you understand. Left half of the wave is the right atrium. Okay, I mean, like in general, forget right and left, but why does the P wave get tall in enlargements? More fibers, there's more to depolarize. But as a result, because it gets taller because there's more atrium to depolarize. When the atrium gets bigger, the current needs to flow across a bigger area than it used to. So as a result, to compensate, what we actually see is that the P wave will increase in heights. But very good that you guys recognize that. But in general, the P wave gets bigger, whether it's wider or taller, because there's more area to be depolarized, essentially. That's an easy way of thinking about it. But really what we see in lead 2 is we see this very tall P wave in right atrial enlargement. And this is what we call P pulmonale. Don't know why that went there. But yeah, so in lead 2, this P pulmonale needs to be over 2.5 millimeters. How many small boxes is this? Okay, before you guys answer that, what's your question? Why doesn't it also get taller? Very good question. Why doesn't it also get taller? Or if you put it this way, again, let's go back. Play it. Let's look at pulmonale. We're talking about lead 2. Why doesn't it get taller? It's a very good question. So let me draw it out for you. Play it. If you put it this way, right? In terms of when the left atrium gets larger, the right atrium usually will not change. So let's say this is the right atrium, this is the left atrium. I know it's terrible, but left atrium, as you can see, is much bigger than the right atrium. But in terms of when we look at the P wave, for example, the right atrium is a lot, here we see, it's much smaller, and as a result, it can contract normally. But what happens is that because the left atrium gets larger, we get a small notch, and then it kind of has to cover for that area. With right atrial, we have to think, for example, the sinoatrial node is here. So as a result, this needs to contract, the sinoatrial node needs to fire higher just to compensate, much higher than it normally does. I know it's a little weird, but the idea here is that, for example, this would get large, and then bam, just decreases because the left atrium is here. But again, it's all about how do you divide the P wave. The P wave, this is right, this is left. All right. But that's a very good question, wallah. Honestly, the questions you guys are asking, absolutely amazing. Well, absolutely important. So it's good that you're asking. Play it. So yeah, we see this very tall P wave in lead 2. In V1, I think the V1, you guys understand why it makes sense. This V1 so let's say this is normal, right? For some reason. What will happen is that this will get larger and this will get a lot smaller. Even this looks taller. This is the isoelectric line. This is because, again, this represents the right, this represents the left. So that's what we see in V1. All right. Again, lead 2, the height needs to be above 2.5 millimeters. How many small boxes is this? 2.5 millimeters. 2.5 small boxes. Very good. And V1 or V2. So you can look at V2, but usually we look at V1. But we can look at V2 as well. The P wave should be above 1.5 millimeters. In height, it should be this increase should be above 1.5 millimeters, which we see here. Why can this happen? Think, why does left atrial enlargement happen? And then put it on the opposite side. So rather than systemic hypertension, we'd have pulmonary hypertension. Rather than what's it called? We could have, because of mitral regurgitation stenosis, eventually over time, these are more likely to be seen with the left side. Instead, what's more common with the right side would be tricuspid. So tricuspid stenosis or regurgitation. This would happen over time. Eventually, it could get to the right atrium, but really, it's more likely that you'd have tricuspid, as you can see, tricuspid or pulmonary stenosis. But yeah, play. Now this is a practice question. What do you think? What are the abnormalities here? Like, what do you notice? So really, the nice thing, because we know we're talking about atrial enlargements, we only really need to look at 3 leads: 2, V1, V2. What do you say? Okay, someone said mitrale. Very good. I see the mitrale as well. Is there anything else? Well, are we good? And I'm not implying that there could be something else, but I'm just asking, do you guys notice anything else? Is it both atria? Okay, why? That's a very good question. Why do you think it could be both atria? Tall P, which lead? This. Why do you think it could be both atria? V1, V2. Okay, let's look at V1. The P, the P in V1, we see it actually looks deep if you think about it. It's more deep than large. So this looks like left, but in V2, this P wave is actually very tall. It's a very good point. So V2 has a very tall P wave. So what is your final diagnosis? What do you think this 30-year-old lady with shortness of breath or sob on exertion it has? Biatrial. Let's see if you guys are correct. Oh, wait, they asked you. Okay, you guys say biatrial, final answer? You're correct. Mashallah alaikum. Yeah. This is very good to familiarize yourself with and what to look for in V2 and V1. I'll stay there, but it's good that you guys understood the biatrial enlargement without me having to explain, but I will explain it for those of you who didn't understand. Basically, in biatrial enlargements, biatrial means both atrials. So we have two atria. So as a result, we need to see features of both right and left. Mitrally, is this a feature of right or left atrial enlargement? Left. This deep P wave in V1, is this right or left? Left again. This tall P wave in V2, is this right or left? Right, very good. For that, we have features of both right and left. As a result, biatrial enlargement. Do you guys understand atrial enlargement? Are you confident that if you saw an atrial enlargement, you'd be able to identify it? Are you any semi-confident at least? Yes, yes. Inshallah, you guys are confident. Inshallah, hopefully, you will be, inshallah. I believe in you guys. Now, ventricles, how do we represent ventricles? What really represents the ventricles are QRS? I said QRS, معلش. طيب, QRST, it's the QRS that represents it, really. But there could be widening, but really what we see is actually that there's just one increase in the amplitude in terms of the ventricles. So that's what we see in terms of the ventricles. And no, there's an increased amplitude. So there's more muscle, like I said, more electrical activity. So as a result, the amplitude is going to increase. Now, fun fact, right ventricular and left ventricular hypertrophy are frequently diagnosed as acute myocardial infarct and may result in patients incorrectly treated. Okay, so here we have the frontal and the transverse planes, and basically with the ventricular enlargement, we don't look at the we don't look at the limb leads or we don't look at the bipolar or the augmented leads. We look at the precordial leads, which are V1, V2, V3, V4, V5, and V6. V3 isn't too important, so V3 is not important today. Bye V3. But V1 and V2 are pretty important for right ventricle. If you think about it, just they're showing you structurally, where is it? And then V4, V5, and V6, they represent the left ventricle. So to see right ventricular enlargement, for example, we would see an increased amplitude in V1 and V2 if we have right ventricular hypertrophy. If it's left ventricular hypertrophy, V4, V5, and V6 would have increased amplitude. And if you think about it, it makes sense because we said the QRS will increase in amplitude if we have an increase in amplitude for those particular leads. So V1 and V2 represent the right ventricle. So as a result, if their amplitude is increased, we have right ventricular hypertrophy. The opposite is true for left ventricular hypertrophy. And we'll see examples of that now. This is the normal QRS, which you should all be familiar with by now. What do you guys see here? We're talking about hypertrophy. You don't even need to look at leads 2. We can forget lead 2. But we're looking at precordial leads from V1 to V6. So what do you guys think is the abnormality? Okay, let me rephrase the question to make it a little bit easier. Where do we see the high amplitude QRS complexes? Which leads do we see in this case? So the QRS complex should be increased in ventricular hypertrophy in terms of amplitude, and certain leads represent certain parts of the or certain ventricles. V1 and V2, yes, they do have high amplitude. So this is right ventricular hypertrophy, absolutely. You look at the amplitude, it's going beyond the paper, mashallah. This is a very big right ventricle. So yeah, this is right ventricular hypertrophy. V1 and V2 have a significant elevation, even V3, so it's not too important for right ventricular. So yeah, what happens actually in V5 and V6 is that what we see is that it actually gets smaller. So we have these really tall QRS complexes in V1 and V2, and then it gets smaller as we go down to V6. So the S waves are deeper as a result in right ventricular hypertrophy. And the S waves are deeper in the leads that go to V6. But usually we can also, when we see right ventricular hypertrophy, this can also be supported by right axis deviation. Do you guys think this has right axis deviation? Like, do you think there's right axis deviation here? You don't think so? It's very hard to tell, to be honest, because this is confusing. Lead 1 is kind of throwing me off. But in general, just remember with right axis deviation, when they're going to ask you guys about it, it might be pretty obvious. But the QRS, the QRS on 1 should look downwards. So it will look like this for right. And AVF will look like this. It will look up. So AVF will be positive, lead 1 is negative. So if they're looking at each other, that's right axis. It's not very clear here, to be honest. But I think there are going to be examples where it is. And here they're just showing you how it changes progressively. And here they're showing you the axis will become right axis deviated. There are certain criteria. So pretty much the R wave should be greater than the S wave in V1, or the R wave should be greater in 7 millimeters, greater than 7 millimeters. 7 millimeters, how many small boxes is this? 7, yeah, exactly. Just remember, each small box is 1 millimeter in height and 1 millimeter in width. For 7 millimeters, it's 7 small boxes tall. There are other criteria as well. Right axis deviation, this supports it. T wave inversion in V1 does support it. S waves in V5 and V6 supports it. But the main thing you need is a very tall V1 R wave in V1, greater than 7 millimeters. If I remember that. But yeah. Just because there are if you have T wave inversions in V1, V2, and V3, but the R waves are very tall, this is a very common reason why you might think that there's acute ischemia, but there isn't. There's actually right ventricular hypertrophy. And that's why they said earlier, in the right ventricular hypertrophy is often confused with acute ischemia. As a result, it's mistreated. But let's say you guys, let's just think, how could you avoid any? You think this is ischemia, but you never knew about the 7 millimeter rule for the R waves. What's something else, you might do to confirm if this is ischemia or not? What's something you can check? But forget the RVH criteria. And what can you do? We can look for some. Yeah, we can look for a STEMI. But how are you going to look for a STEMI? What are you going to do to look for a STEMI? Okay, just to clarify it, you could look at all of the leads first of all, because they don't all show here. You might see, for example, an ST elevation in 2, 3, and AVF. But it's pretty important that you could do a 15 lead ECG. So because usually if you see an ST depression in V1, V2, V3, you might think that there's actually reciprocal towards the posterior, which would be V7, V8, and V9. But you could always just check the posterior leads. You're doing the ECG anyways. But they don't need to do that because there is criteria for right ventricular hypertrophy. So you don't need to do a you don't need to do a posterior ECG. But I just wanted to ask you guys, if you think this might be a posterior MI, what would you do? That's all I'm really asking. I apologize if you're confused. But just to clarify, we know that this is right ventricular hypertrophy because the R wave is taller than it's taller than 7 millimeters. It's taller than a lot more than 7 millimeters actually. In V1. There's T wave inversion, which helps it. T wave inversion is normal in right ventricular hypertrophy. We can't tell right axis deviation from here. And we can't see S5 and S6. We can't see V5, V6, but there could be S waves. Well, yeah. Causes pulmonary disease, pulmonary hypertension, anything that could just make the right ventricular have a lot of pressure in it. There could be right bundle branch block, Wolff-Parkinson-White syndrome, and these are differentials for right ventricular hypertrophy. Here, what do you guys see? Or before that, do you guys understand right ventricular hypertrophy pretty well? Yes, alhamdulillah. Okay, good. Here, what do we see? Also, any points, again, if you guys have questions, please ask. But what is the abnormality here? What do you guys see here? That's abnormal. LVH. Okay. MashaAllah. How did you know that this was LVH? I mean, just basically what popped out to you that told you this is LVH? Deep R. Oh, wow. Okay, you know a lot, mashallah. Deep R waves in V1 and V2. That is actually a criteria. And you should just teach this for me instead. This before the deep R waves, there's also something else that we could identify that's even more important. But the fact that you know deep R waves is impressive. Mashallah. That's good. Tall R wave, V5. Yep, absolutely. So V5 has a tall R wave, V4 has a tall R wave, V6 has a tall R wave. This is left ventricular hypertrophy. But yes, there's deep, very deep R waves in V1 and V2, and these very tall R waves in V5, V6, and V4. Now, you're probably wondering, why is the doctor doing math? Well, in right ventricular hypertrophy, we just said we needed the tall R wave. But in left ventricular hypertrophy, we actually need to do math. So we need to add the height of V5 or V6 to the depth of V1. So 21 plus 17 is 38. Don't worry, guys, it's basic addition. It's math that we can do as med students, I hope. So yeah, we have this R wave, it's 21 millimeters tall. As a result, when you add it with this, deep S waves, my bad. No, I understood what you meant. I completely understood what you meant. It's all good. It's easy to mix them up all the time, but you're still correct. The idea is there. Yeah, the S waves here, they're very pronounced compared to the R wave. The R wave is like small. Here's the huge S wave, really, really big S wave. Well, yeah. So pretty much the S waves, they look much deeper on the leads that represent the right ventricle, which are V1 and V2. And the reason the doctor is doing math is this. You need the S wave in V1 plus the R wave in V5 and V6. And if it's greater than 35 millimeters, as a result, you know you have left ventricular hypertrophy. There are other criteria. If you go on your original slides, there are other criteria, but the doctor only wants to know this criteria right here. The other criteria, there's a lot of them. Don't tire yourself with them. Also, if the patient is under 35 years old, this needs to equal 50 millimeters. But this is a very, very massive R waves. So what do you guys think is going on here? They're extending to the name of the hospital. This guy's got a very big ventricle, but which one? A left ventricle, very good. And here they're just highlighting the different criteria. Again, right ventricular hypertrophy is associated with right axis deviation. Left ventricular hypertrophy is associated with left axis deviation. And you may see this thing called left ventricular strain. And this is how it looks. It's like this little curve. It looks kind of like an ST, sorry, not an ST, a T wave inversion, but it's very subtle. Different causes. It's not always pathological. Some athletes actually have left ventricular hypertrophy, but it's a different type of hypertrophy. Is the same thing in RVH, the strain. RVH doesn't necessarily have strain. It has T-wave inversions rather than strain. Well, they just call this like baby T-wave. It's like a T-wave inversion here. Like this looks like a T-wave inversion, but it's like a baby T-wave inversion. So it's a strain. A good question. Risks of left ventricular hypertrophy, congestive heart failure because of volume and pressure overload. Arrhythmias, again, can cause left ventricular hypertrophy. Aortic stenosis because of the pressure, regurgitation pressure, hypertension because of the pressure, hypertensive cardiomyopathy pressure. You guys get the idea that that pressure causes left ventricular hypertrophy, right? Like I think I said the word pressure more than anything else today, but that's what causes it. Yes, pressure. Okay, good. But I guess we're done with the hypertrophy. And that's pretty much the lecture with the exception of some practice. So we do need to practice. And then I have some summary slides I want to show you guys that you can screenshot and that are important. So what do you guys see here? Left ventricular hypertrophy. You're correct. Like next. Left ventricular hypertrophy. Very good. Next. What about here? Left ventricular hypertrophy plus left atrial enlargement and left axis deviation. Because okay, left axis, look at the QRS complexes. One is positive, AVF is negative. So one left. That's what it looks like. Very good. Next. Also, make sure you mention whether or not there's axis deviation because some of the questions do ask for axis deviation. Let's see. Left ventricular right ventricular hypertrophy. Okay. Left plus right ventricular hypertrophy. طيب. Interesting. سعيد. عوافي. Right ventricular with right atrial. Okay. So you are correct. Right ventricular hypertrophy with right axis deviation, not right atrial enlargement. So this is fine. That's around 2.5 small boxes. There is no atrial enlargements, but it's okay. We all tried, you know. Again, like I said, أهم شيء we get it wrong now and move على exam. Good job, guys. You identified right ventricular hypertrophy, which makes me very happy. But what out here? The left ventricular hypertrophy. Okay, so someone said left ventricular hypertrophy. With left atrial. Okay. طيب. Anyone else want to say anything? You guys are correct. Left ventricular hypertrophy with left atrial. Here we have mitrally. The two peaks have around a millimeter between them. And then, for example, again, the left atrial portion has this depression. We can even see that in V2 as well. In left ventricular hypertrophy, you guys can just see how the R waves versus the S waves felt very good. Okay, here. Left ventricular hypertrophy with biatrial. Interesting. Anyone agree or disagree? All right. You guys are correct. For those of you who aren't sure, so here we have a tall R wave. Sorry, tall R wave, tall P wave, above 2.5. This is tall. That's a sign of right. If we look at V1, we have this deep, that's a sign of left. And we don't really see much in V2. So we have a sign of left and right. So as a result, we have biatrial enlargement. And if you look at left ventricular hypertrophy, it's there as well. Okay. Now you guys are probably wondering, or not wondering, you're probably way too tired to wonder. But what about bilateral ventricular hypertrophy? Do you guys have any guesses on how that would appear? Because there aren't any examples and you don't need to know this. But I feel like it's, in case any of you guys do end up wanting to look more into this, that you do have an answer. Does anyone have any guess? Just guess. How would it appear? Okay, you guys. Oh, V1, V6. Okay, that's a good guess, but not exactly. What we'll see is left ventricular hypertrophy with right axis deviation. So that's an indication that they may have bilateral ventricular hypertrophy. But thank you for guessing. It's a very good guess. I would have guessed that first. Okay, here. What's the abnormality? Left atrial enlargement. Very good. Here. Right atrial enlargement. Very good. Here. Left ventricular hypertrophy. Very good. Played. There are some other ECG waves that you might see. You might see this thing called a U wave. U wave is a sign of hypokalemia, and this represents something called the delayed parts of the repolarization. So when there's a delay in the repolarization, you might get a U wave, and this can happen with hypokalemia. Now, you don't need to know this, for example, for the arrhythmias lectures, but it might have been mentioned in a lecture here or there. But I wanted to include it just in case. The other thing in cardiac tamponade, we have something called electric alternans. Electric alternans is when the QRS has like this alternating morphology. So if you look here, for example, here the QRS complex is big, here it's small, big and small. That alternates in size. That happens in cardiac tamponade. Here's a summary of some really important things that you guys should know. Oh, I'm even going to send a picture of this in general, but this is the last slide on, besides the thank you slide and the feedback slide. But yeah, this is some things I think are very important, including the algorithms, which are really useful. The how to identify, for example, which parts of the heart is affected in terms of the atrial ventricles, whole heart. The blood supply is very important. These are all things I think are very important. Thank you so much, guys. Really, I know we spent a lot of time looking at a bunch of squiggly lines, but I hope you guys benefited, and I hope that, inshallah, when you get the questions on the exam, that you'll be very confident in solving them. And of course, I think the real ECG Crash Course is the friends we made along the way. Of course, please, your feedback is very important and appreciated. And personally, I'm someone who's very open to feedback, and you guys have probably given me feedback before. I change based on that, but you also have the right to give your feedback privately, so make sure you do so. And if you have anything that you didn't like about this crash course, anything you want to change, please let me know. I'm more than happy to explain everything all over again, but I'll need a full night's sleep, inshallah, first, because 6 hours is a long time. Oh, you take من العافية. شكرا.